For the record, my name is Brian Worrell, District 4 City Councilor, and I'm the chair of the Boston City Council Committee on Ways and Means. Today is May 14, 2024. This hearing is being recorded. It is also being live streamed at boston.gov/city-council-tv and broadcast on Xfinity Channel 8, RCN Channel 82, and Fios Channel 964. The Council's budget review process will encompass a series of public hearings that began in April and will run through June. We strongly encourage residents to take a moment to engage in this process by giving testimony for the record. You can do this in several ways. One, attend one of our hearings and give public testimony. We will take public testimony at the end of each departmental hearing and also at 2 hearings dedicated to public testimony. The full hearing schedule is on our website at boston.gov/council-budget. Our next scheduled hearing dedicated to public testimony is Tuesday, May 28th at 6 p.m. You can give testimony in person here in the chamber or virtually via Zoom. For in-person testimony, please come to the chamber and sign up on the sheet near the entrance. For virtual testimony, you can sign up using our online form on our Council Budget Review website or by emailing the committee at ccc.wm@boston.gov. We are called to testify. Please state your name and affiliation or residence and limit your comments to a few minutes to ensure that all comments and concerns can be heard. 2, you can email your written testimony to the committee at ccc.wm@boston.gov. Or 3, submit a 2-minute video of your testimony through the form on our website. For more information on the council budget process and how to testify, please visit the council budget website at boston.gov/council-budget. Today's hearing is on dockets number 0670 through 0672. Orders for the FY25 operating budget, including annual appropriations for departmental operations for the school department and for the other post-employment benefits. Docket number 0673 through 0675. Orders for capital fund transfer appropriations. Docket number 0676 through 0678. Orders for the capital budget, including loan orders and lease purchase agreements. These matters were sponsored by Mayor Michelle Wu and referred to the committee on April 10, 2024. The focus of this hearing will be to discuss the FY25 budget for the Boston Public Health Commission, including an overview, infectious disease, child, adolescent, and family health, violence prevention, and behavioral health and wellness. Today, I'm joined by my colleagues in order of arrival: Councilor Fernandez Anderson, Councilor Flynn, Councilor Braden, Councilor Mejia, and Councilor Fitzgerald. Today's panelists consist of, on behalf of the administration, Commissioner of Public Health, Executive Director, Dr. Ojikutu, and Director of Administration and Finance, Director Harrington. We are also joined by our students from Meridian Academy. I just wanted to say hi to you guys. Now I turn it over to the panel for your presentation.
Good morning, Chairman Worrell and distinguished city councilors. I'm honored to be here before you today to present on behalf of the Boston Public Health Commission and our more than 1,300 dedicated employees who work tirelessly every day to improve health and wellness in the city of Boston. For the record, my name is Dr. Basola Ojikutu. I'm the Commissioner of Public Health for the city of Boston and the Executive Director of the Boston Public Health Commission. I'm joined here today by Tim Harrington, the Director of Administration and Finance, who will discuss details of the FY25 recommended budget. This morning, I'm going to provide an overview of the Commission's work detailing some of our accomplishments and achievements over the past fiscal year in the areas of youth and family health, violence prevention, infectious diseases, and mental and behavioral health. During this afternoon's hearing, we will hear from Chief Hooley on Boston EMS, which is one of our 6 bureaus within the Boston Public Health Commission, and I'll provide further details on our work in homeless services and recovery services. So to get us started, just a little bit of history. The Boston Public Health Commission is the oldest public health department in the country, and we are also a leading agency in regards to racial, social, and health justice work. To reflect our commitment to these issues, we have recently revised our mission statement, and I'd like to begin by sharing that. So this is our new mission statement on the slide: to work in partnership with communities to protect and promote the health and well-being of all Boston residents, especially those impacted by racism and systemic inequities. We do this work under the direction and guidance and supervision of a 7-member Board of Health, which is appointed by the mayor. The board is responsible for appointing the Boston Public Health Commission Executive Director, approving our budget, and has independent regulatory authority over our role, and that's under state law. The board is comprised of leaders in healthcare, public health, as well as organized labor, and they provide strategic guidance to our work. We achieve our mission by doing a number of really important tasks, and those include providing direct services through EMS and our Homeless Services Bureau, as well as our school nursing staff. We also do an incredible amount of work in terms of community engagement and advocacy, do a lot of work in health, education, and services of that nature to improve health literacy, and certainly, and I will talk a bit about our data collection and surveillance work, which is fundamental to what we do. All of our work is founded on the fact that we believe that prevention and public health are important for health and wellness for the city of Boston, and it's really the foundation of the work that we're doing here in Boston to improve health and well-being. So I'm going to turn it over to Tim to talk about our budget in detail.
Good morning, councilors. My name is Tim Harrington, Director of Administration and Finance for the Commission. In these next few slides, I'll provide a brief overview of our proposed FY25 budget for all of our bureaus, review our proposed new investment requests, and provide a brief update on our capital improvement projects. Before I begin, I want to thank Steve Simmons, our Chief Financial Officer, Chris Valdez, our Budget Director, and Aaron Brunette, our Budget Specialist, who have worked hard over the last several months on the proposed budget. The first slide is our proposed maintenance budget for FY25 at the bureau level. You can see that for the most part, the bureaus are seeing mostly increases. This is mainly due to increases in personnel costs, including various required step increases for our union personnel and several proposed new investment requests that I'll describe in a subsequent slide. Recovery is increasing by 5.4%. The Child and Adolescent Family Health Bureau by 8.9%. That includes one of our new investments. And Community Initiatives is increasing by 7.6%. EMS's total budget is increasing by 10.8%, in addition to a new investment I'll describe shortly. Their budget includes increases due to the settling of their union's collective bargaining agreement and anticipated increases in their revenue for FY25. The Infectious Disease Bureau is increasing by 7.3% and Homeless Services by 12.6%. The Homeless Services increase is due to a proposed new investment to support low-threshold spaces in the city. You'll notice that our public health service centers, which includes our IT department, research, communications, and several other administrative departments, is decreasing by 0.8%. That particular decrease is due partly to the city's decision to handle the rent payments at our headquarters at 1010 Mass Ave in a different manner. In years past, the city would give us the rental cost in our budget, and we would pay it back to them. This year, the city has consolidated lease arrangements like that into the city's public facilities department, which handles the maintenance for that building. In essence, that caused a decrease in our budget line of over $1 million for FY25, but has no impact on our operations. You can see that there is a decrease in our overall administration line of 3.2%, but this is because we shifted most of our non-union COLA increases that we received in FY24 over to the other bureaus in FY25. All of those increases were essentially parked in the administration line at the beginning of FY24. Regarding our property department, that department will essentially be level funded. In FY24, that department received a 15% increase to assist with increased utility costs that we have seen recently. The total proposed increase for our entire budget is 6.8%, which is similar to increases the Commission has seen in the last several fiscal years. For our OPEB costs, our budget office has been working closely with the city's Office of Budget Management over the last several months. While in years past, OPEB was shown as its own line, we've decided to move those costs into the specific bureau lines. This results in a decrease in that particular line and then an increase by several percentage points in each specific bureau. The following several slides will highlight our proposed new budget requests. The first request is for an additional $1 million to support our low-threshold sites. BPHC continues to work with the city to support several low-threshold sites around the city. These are the sites that have been set up over the past 2 years with funding from the state, the city, and BPHC to provide additional low-threshold beds in response to the increased number of unsheltered residents in the Mass and Cass area. We will continue to work with the city and the state to refine the plans for these sites over the next several months. Our second request is a new initiative to address disparities in infant and maternal health through the creation of a fetal infant mortality review and the expansion of an existing program to bring home visiting services to more of our families most at risk in Boston. The Fetal and Infant Mortality Review is a community-based process aimed at improving services for infants and families through investigation of cases and dissemination of findings and recommendations. Home visiting is an evidence-based strategy to improve maternal and child health outcomes by providing parenting families with a visit from a nurse to answer their questions and connect them with resources. The third new investment request is from Boston EMS for 12 additional EMTs to meet the rising demand for service. You'll hear more from Chief Hooley and EMS this afternoon regarding this particular request. The next several slides relates to our new capital improvement projects that we have submitted to the city for their review and consideration. First is a boiler replacement at our Mattapan Transitions building. Transitions is a 65-bed short-term substance use treatment program for adults. This adds to 2 existing requests to the city for upgrades to this building's HVAC and electrical systems. The second new request is a chiller replacement and related HVAC upgrades to the Northampton Square complex, including Boston EMS headquarters. And the last 2 budget slides provide a brief update on several significant ongoing projects at BPHC. First is the new addition to the Woods Mullen shelter. The addition includes a whole new entrance, 2 new bathrooms on the 2nd and 3rd floor, and a new elevator. The new addition is open and in use, but there are some final punch list items that need to be completed over the next few months. The second update here involves the Northampton Square garage. This project is in design currently. It includes repairs to all the cement work and drainage systems throughout the garage. Construction is currently scheduled to begin this summer. And 2 other brief project updates. One is the electrical separation work at our Northampton Square complex. This project commenced last Monday, May 6th. The goal is to separate the electrical meters as between the BPHC areas of the complex and those areas owned and controlled by Trinity Financial to provide for a more efficient billing mechanism for both parties. And then lastly, the city has approved a new HVAC system for the Transitions building at the Mattapan campus. There's no timeline yet for that particular project, but we'll continue to work with the city to move that project forward. Again, these are all capital projects that are being funded by the City of Boston and handled by the city's Public Facilities Department. I'm happy to answer any questions about these projects or our budget generally, but for now I'll turn it back to Dr. Ojikutu.
Thanks, Tim. So I'd like to talk a little bit about workforce and infrastructure. In order for us to provide high-quality services to our residents, we certainly need a strong and capable public health department. So I want to start by thanking Mayor Wu and you, the City Council, for your support of our infrastructure requests during last year's budget cycle. We were able to improve our human resources and finance infrastructure, which has been incredibly helpful. And because of these investments, we've really been able to strengthen a lot of what we're doing in terms of our programming and streamline our efforts. These efforts have also been strengthened by a public health infrastructure grant that was awarded by the CDC, which has been incredibly important for us as we build our capacity and think about professional development and other work that we want to do to improve our staff. Our accomplishments over the course of the last year include the development of our 2024-27 strategic plan, which I think is really important because it outlines the direction of the Boston Public Health Commission. We've also appointed a chief people officer. We've made improvements to our recruitment process, and we've expanded professional development opportunities, as well as we've increased our work to focus on retention and really to make the Boston Public Health Commission a great place to work. Looking ahead, we're committed to promoting staff well-being, increasing morale, and ensuring a pipeline for future public health leadership. I think that one of our mottos is that our staff are our most important asset as we strive to build a healthier Boston. Turning to health data, which is really one of the core functions of any public health department, I'm really proud of the work that we've done to both collect data, focus on surveillance, and to think about ways to act on our data. I think that one of the ways that we've been very effective this year is in issuing our Health of Boston reports. These reports, as many of you all have seen and maybe have quoted from, have really focused in on some key areas around chronic diseases, as well as life expectancy and mortality, maternal health, mental health, and other topics that I think are incredibly important to the health of Boston. One of the things that I think is really important is that not only do we provide trends in how our residents are doing and think about ways that there are continued inequities and persistent and sort of pervasive problems that we know we need to address, but we're really thinking in a forward and visionary way about how to address these problems. And a lot of what we've done is sat and talked to some of you all about how we should go about addressing issues like disparities that are evident in maternal and infant health and infant mortality, as well as mortality and life expectancy. I also want to mention that I know that we've discussed this before, access to care, thinking about pharmacy access, access to our community health centers, as well as our tertiary care centers. We do have a Health of Boston report that will be issued soon. I'm hoping that that will be available for you all to review within the next couple of weeks. As you see here on this slide, we are providing an overview of exactly where pharmacies are located, exactly where urgent care centers are located, where our community health centers are located, and how our residents can access them using public transportation. A really key component of our work is community partnerships, and that is really how we serve our residents, is to actually engage them and to have equitable relationships and collaborations. I would like to give a few examples of these partnerships, many of which you probably know something about already. One of them is with our colon cancer screening campaign. One of the inequities that we know is persistent across the city of Boston as well as across the U.S. is that Black individuals have the highest rate of mortality due to colon cancer. And this is an ongoing concern. And so one of the ways that we're tackling this is through a colon cancer screening campaign to increase awareness of different ways to screen and prevent colon cancer. So this was a process that we went through with numerous community stakeholders, as well as focus groups with community members, to actually understand how to craft the messaging around this particular issue. And it's been quite successful, and we've gotten a lot of very good feedback. Another example of our community partnership and engagement work is our Community Action Network, which has been in place for many years. It's within our Healthy Start Systems division. The Community Action Network has been very instrumental in being involved in the new programming, ways that we have strategically approached issues regarding maternal health and infant health, and just overall supporting families. Tim already mentioned the fetal and infant mortality review. That is an initiative that was advocated for by the Community Action Network, and we're happy to move that forward. We think that that is an incredibly important piece of us, narrowing the gap between Black and white infant mortality in the city of Boston, which I'm sure you all are aware is fairly significant. The infant mortality rate in 2021 for Black infants was over 9 per 1,000 live births, and for white individuals it was 3. So it's a more than 3 times higher infant mortality rate for Black infants. So the Community Action Network has taken these data and really thought through how to improve the work that we're doing, and one of the ways is through this fetal infant mortality review. So we're very happy to move that forward. And lastly, I want to mention that I talked about the data in the previous slide. I think it's important to note, and I appreciate that a number of city councilors have attended our dissemination events. We don't just create data just to have it sit online. We want to make sure our residents are aware of it. So we've held numerous community engagement events where community members can hear about the data in their own local neighborhoods, and they can provide suggestions in regards to programming and strategic initiatives. So turning to child, adolescent, and family health, I think it's really important to acknowledge that together with Mayor Wu, we believe at the Boston Public Health Commission that Boston must be a place where children and family can thrive. And this particular bureau provides an array of services that I know that many of you all have been engaged in and are aware of, ranging from school-based health centers, where we provide a critical array of services provided by nurses and other healthcare providers, to other types of youth programming just across the age span that includes early childhood mental health, as well as up to a lot of the work that we're doing with adolescents, which is incredibly important. I think it's really important to note here, I did speak a bit about the fetal and infant mortality review in the last slide. A lot of the work that we're doing here is focused around children and families, and one of the things that we do that's critically important is home visiting services, and we would like to expand, given what I just told you about the inequities in infant mortality within the city, to really think about how we could do more with home visiting services, have more healthcare providers out there who can actually visit folks, provide prenatal education, breastfeeding support, parenting support, mental health counseling, case management, and so on. So we would really like to expand the work that we're doing there. I also want to mention a program that also I think needs to be expanded is father friendly. We do a lot of work with birthing individuals, with in most cases mothers. We do put forth effort in regards to engaging fathers, and I do think that's an incredibly important piece of the success that we can talk about within the Boston Public Health Commission, but we would like to expand that work. So a lot of great things happening, but we can certainly be doing more. So turning to violence prevention, BPHC is committed to addressing violence through a public health lens, and one that's focused on both primary, secondary, and tertiary prevention, and certainly in close coordination with the city as well as our public safety partners, but really, as I said, focused in on what can we do from a public health and prevention lens, focused in on racial equity and acknowledging racism as a root cause of violence. So within the Division of Violence Prevention, we have a number of programs that I know that many of you all are quite well aware of. We have the Community Healing Response Network, which is the new name for the Neighborhood Trauma Teams Network, that is, instead of focusing on trauma, it's really focusing in on healing and the assets-based response within communities. So we're excited to see that move forward with a different philosophical approach. Many of you all know about the Safe and Successful Youth Initiative, or SSYI, which provides case management to vulnerable youth 17 to 24. We have a newer program, the Men's Health Initiative, for individuals over 24 who are also at risk. And certainly the work that we do comprehensively across violence at the Family Justice Center is still very important. I know that many of you all have benefited from the Capacity Building and Training Institute and the work that's been done to train some of your own staff members in terms of trauma and resilience. We hope to build on that. We think working across city departments is of critical importance. And then I just also want to mention the Violence Intervention and Prevention Initiative, which really looks at this idea of what can a community do to become more resilient, to realize that there are supports and there are assets, that there are ways that we can work as our own communities to prevent violence by developing neighborhood teams, to think about what our youth can do, and to really be agents of change within our own communities. Lastly, I want to highlight a new and very exciting initiative that we have within the Child, Adolescent, and Family Health Bureau, which is the development of an Office of Domestic and Sexual Violence Prevention. We are very close to finding a director of that office, and once that director has been hired, we will move forward and hopefully in hand with you all to think about what the strategic objectives of that office will be. We know that there are many different ways that we can work. There are a lot of people doing this work throughout the city. We're thinking about coordinating a lot of that work, thinking about data and understanding how to approach it in better ways, and we're very excited to see that move forward. Turning to mental and behavioral health, this is, of course, a major priority of the Boston Public Health Commission and certainly of City Hall, and I know that many of you all are very interested in this work. In FY23, we established the Center for Behavioral Health and Wellness, and we did this to really find more strategic and collaborative ways to reduce behavioral health inequities. And it was quite clear through our Health of Boston mental health report, many of these related to youth. I mean, you see the data here for Boston high school students in 2021, those who said that they felt sad, empty, hopeless, angry, had overall mental health symptoms, only 43% actually received the help that they needed. So clearly there's unmet need, clearly work that we need to do. So within the Center for Behavioral Health and Wellness, we have worked very tirelessly with a small team, but a really dedicated team to develop a series of initiatives that are moving forward. They're being funded. You all heard about the announcement in March with primarily ARPA funding, but other sources of funding to think about how to create a trauma-informed school system, as well as to think about how to capacitate, all of us in how we manage trauma and how we understand the needs of young people particularly, but young people within families, young people within our communities. So I think that all of these new initiatives are very exciting. We look forward to moving them forward. If you have a chance, we are having some youth mental health summits. One was yesterday. There's going to be one for parents on May 28th and one for providers on June 3rd. This is an opportunity to actually talk to people, to get a sense of what their needs are, to understand their understanding of the kinds of work that we're doing. And I think it's exciting because it's truly a citywide initiative. And if you need more information about that, I'm certainly available to provide it to you. So I think we're going to stop there in regards to the slides at this point, and I'm happy to take questions or your thoughts on any of what I presented, and thank you for the opportunity.
Thank you. I'd like to acknowledge that Council Weber and Council Murphy has also joined us. Go now to Council Fernandez-Anderson for the first round of questions.
Thank you, Mr. Chair. Good morning. I'd like to ask more programmatic questions and probably won't get a chance to get through everything, but hopefully in the second round get to the more budgetary questions. In terms of violence prevention, can you tell me about the state of violence or what propels violence in the city of Boston as you know it?
So I think it's important to start with the fact that we are one of the safest cities across the U.S. And that means that essentially we haven't seen an enormous amount of gun violence, an enormous amount of penetrative violence. So I think this is an important fact for us to understand. But what it does is that I think it leaves open the for us to understand why and for us to think about how we can keep this and how we can make sure that we're sustained as a safe place. And then I think it also is important for us to recognize that even though we are the safest, one of the safest cities by number in regards to, similarly sized urban centers, that there are many of our residents who still feel unsafe, and that is for a variety of different reasons. So there are many drivers of violence within communities. One of them is inequity and, these issues that we have with structural racism within our communities, when you have community disinvestment, when you have folks who don't feel they have opportunity, when they don't have economic mobility, and there are limited ways that they can, go about achieving what they want to achieve in life, or when they look around and they see other people, achieving things, they may feel as though there aren't other options for them, and that is part of what happens. I think we've talked in detail, both here with the City Council and other spaces, about mental health issues and the problem that we have with not having available access to mental health services, that it's culturally responsive and linguistically appropriate for individuals. And that's something that we've been trying to work on. I think as you look at mental health and you think about exposure to violence in and of itself, it becomes a cycle, and there's an enormous amount of research out there. When we look at some of some communities that have are either lower income or there's been disinvestment, and there is community violence, people who've been exposed over time, there is both a psychological response of anger and aggression sometimes in individuals, and it is about just being in an environment that's been normal, where violence has been normalized, and that may be your reaction and your response. So I think it's complicated in terms of what it is we're looking at in terms of the root causes of violence, but I think all of those issues in some way we're trying to address in some of our programming. I do think that one of the things that's very important about our approach is this switch, in a sense, from looking specifically at the trauma and thinking about what's the healing piece of it. How is it that we can work with communities to heal, to think about what is it about the assets within communities that can be protective and that can prevent and that can engage young people in the process, because I think that young people have agency, and if you provide support for them, then they can provide the answers to a lot of what they're seeing and a lot of what their friends are maybe engaging in. So I think that this is part of how we've structured our programming, is really thinking about this from population level, community level sort of response, as opposed to necessarily thinking about it from a criminal perspective.
Thank you. Mr. Chair, how much time are you giving us for the first round? Because that only says 3 minutes now, and I've only asked one question.
Yeah, it was
Was
7.
it 10 minutes?
It was 7.
No way.
Yeah.
Did you guys see the time?
It was 7.
No way. Thank you, Dr. Jakutu. Can you tell me, and I think you started to alluding in terms of like structuring your program to address some of these issues, but can you tell me then, based on your practices, research, expertise, what then prevents, what is preventative as opposed to interventive? And what are some of those things that you are doing?
So I think that what we've tried to do is both primary, secondary, and tertiary prevention. So thinking to ourselves, what is it that we can do to, first, as an example, train people to manage issues of trauma, because I think trauma is an ongoing sort of process, and unfortunately is very frequent within our society. So we have the capacity building and training initiative, which I think is an important way that we've tried to engage individuals and, first of all, to understand trauma, to recognize it, particularly in children, but to recognize it in family members, for your staff to recognize it in residents and your constituents, and to be able to mitigate it. So I think that's one strategy that we've used. We've thought about this from the perspective of interacting from a case management level with people who are both at risk of being a victim of violence as well as perpetrating violence, from the Safe and Successful Youth Initiative as well as the Men's Health Initiative. So SSYI, the Safe and Successful Youth Initiative, is for individuals 17 to 24 who have been identified as being at risk, and providing them with case management services, which includes behavioral health and mental health services, as well as thinking about jobs and ways to engage and ways to, interact with their peers and in the workplace. So these are important individual level strategies. The Men's Health Initiative was established because we realized that 17 to 24 wasn't enough. There are many people older than 24 who also need similar services. So providing those services in the same way, case management, sort of a case management approach, has been very important. I think I do want to highlight that for both of those two programs, we are over-enrolled, meaning that we have more people who...
So you're still listing interventive services, right?
Correct. Yes. I just want to let you know that both of those two, we have more people than we initially planned to have in those programs. So they're definitely, subscribed, and people are very interested. We also have the Violence Intervention and Prevention Initiative, which is more at a community level. So again, thinking about communities, can we put together, neighborhood teams of community members, stakeholders who can talk amongst each other about what they can do to prevent violence within their own neighborhoods, and provide them with resources so that they can work together to think about strategies, initiatives that they can move forward amongst themselves, because they themselves have the lived experience in order to address these issues. So that's VIP, or the Violence Intervention and Prevention Initiative. And then we, of course, have what we talked about, the Community Healing Response Network, or the new name for the neighborhood trauma teams, which I mentioned is really important because, one, if you look across the country, don't oftentimes have, or I think Boston is one of the very few places where we have this network of individuals within communities who are responding. So not preventing primary prevention, but really responding and thinking, how do we prevent this from happening again? So secondary prevention and even longer term prevention.
Could you clarify, just in closing, the difference between the two?
So primary prevention is before something happens, and then secondary prevention is after something happens to prevent it from happening again.
Examples of the two.
Right, so let me give you an example. So maybe we could take the Violence Intervention and Prevention Initiative. You'd bring a community together and you'd say, okay, so what should we do to provide after-school programming, for kids so that they aren't on the street and so they have a place to go that's productive. So that would be before something happened. Of course, we all know things have happened, but before a key incident happens. In terms of secondary prevention, you'd be talking about, so if we have a penetrative incident, so gun violence occurs, so then our neighborhood trauma teams, now called the Community Healing Response Network, they go to the scene of the crime, and they are there when it happens, but they're also working towards healing not only the family and the victim's family, the immediate family, but thinking about the neighborhood and thinking about the community and sort of next steps. So that would be secondary prevention. And retaliation. I mean, these are the things that we have to always, think about in these cases.
Thank you, Councilor Anderson. Councilor Flynn, the floor is yours.
Thank you, Mr. Chair. Thank you, Dr. Ojikutu, for being here, and for Tim Harrington as well, for the important work both of you are doing. I'm glad to hear, Dr. Ojikutu, you and your team are working on a kind of a dedicated domestic violence outreach initiative, critically important. I want to acknowledge that. It's an important issue. It's an important issue in my district, especially. I have a high rate of domestic violence related issues. So I want to acknowledge your team for putting that together. Very important. Doctor, one of the issues I've talked with you about in the past and with previous directors as well, the Healthy Boston report, I love reading that. I always asked for a specific capture of the Chinese community, the Asian community in Chinatown, the health and public health challenges they have are dramatically different from the other residents in and around Chinatown, especially the white residents. The Chinese community has we have a high asthma rate. We also have a high gambling addiction rate in other public health challenges. My question, Dr. Ojikutu, we're focusing down into capturing the Asian community in Chinatown and not the broader community that includes others, because I need to get an accurate reflection of the Asian community and their public health challenges. Is that going to happen?
So I appreciate your question, Councilor Flynn. I know we've talked about this before, and my team has put their heads together, because it's not, I would say we want to do a good job. Okay, so we've actually met with a group of Asian and Pacific Islander data stakeholders who are affiliated with Tufts. We've met with them, and we are going to work collaboratively with them in repeating the Chinese in Chinatown door knock survey. So what we're going to do is work on that, which I think is an important initial strategy. But it's also important for us to disaggregate, as you said, and make sure that we're getting issues of nativity, so country of origin. So within, we lump Asian populations and we don't necessarily understand the nuance and where people are actually coming from in their experience. So we're looking at the data that we currently have, and we're also expanding other data because we do have additional data from the U.S. Census Bureau, and we're working on this. So therefore, we will have, within this summer, I'm honestly telling you, we will have something for you that will look at Chinese, Vietnamese, Korean, Asian residents of Boston, and we'll have that data that's more specific to your district.
Yeah, thank you, Doctor. And I know you know my opinion on this, but are we going to have that in the report?
So it'll be a separate report. We're going to do a special report for you.
And it'll be this summer?
I'm reading that it's going to be this, they're saying June, I'm going to say, I'm going to give it to you this summer.
Well,
Okay?
Doctor, I can live with that.
Yeah.
I appreciate you compromising. Thank you for doing that. And my staff is available to help with the report. My staff assistants speak Chinese in Mandarin, and they'll help you and your team if there's any language and communication challenges as well. So I want to say thank you for working with me, working with my team, and understanding the importance of capturing the Chinese or the Asian community, specifically in Chinatown. Because as you know, if you live in the same street as many Chinese residents, or one block over in the Ritz-Carlton, you have a vast different experience in public health challenges as if you live on Beach Street, which is 40 yards away. You could live at the Ritz-Carlton Hotel on the 20th floor, and I'm not criticizing anybody, but 30 yards away is an elderly Chinese family in poverty. So that's why I want to focus on that. I want to say thank you. I also want to, Doctor, I was at a meeting early this morning on Tremont Street, and there was a young woman. She was working on the BEST team. Her name was Frankie. We were talking to outreach people on near the Boston Common, public safety. But this young woman did a tremendous job. She was a BEST counselor, providing services to the homeless community in and around downtown Crossing. Excellent, professional, dedicated. But I also know we don't have enough of them. We probably have 10 or 12 citywide, maybe. Is there more in the budget for the BEST team?
So the BEST team is the Boston Emergency Services Team, a critical service that we provide that allows for behavioral health intervention throughout our city. I would say that we are going to have a longer discussion about this afternoon.
Okay.
When Chief Hooley is here, and I'd like to defer that a bit because I think there are a number of strategies that we're thinking about and utilizing that have been successful and that we can think about in terms of, you're asking about additional funding later this afternoon, if that's okay with you, Councilor Flynn.
Doctor, that's perfect. I appreciate that. I have one more minute left. Doctor, HIV, AIDS, hepatitis C, critical issues throughout the city, supporting people living with HIV, patients, hepatitis as well. What is in the budget for supporting patients with those infectious diseases, but also prevention? And what are we doing to ensure that we provide the best care and outreach to those people?
So it's an incredibly important point. Just starting with HIV, we all know Boston, if you look across the state, has one of the highest average annual HIV infection rates, and that's just the nature of being an urban center, which I think is important for us to recognize. Those numbers have been going down, and we know that that is the case because treatment is available and treatment prevents transmission. There are two programs that I need to mention. So within our Infectious Disease Bureau, we are funded through the Ryan White Care Act to provide services to many different types of providers, and these providers are caring for people living with HIV. They're providing case management services, housing, mental health services, all of those services in a comprehensive package, and we're very lucky to have those services available. This actually reaches outside of Boston, so it's within the eligible metropolitan area. We are also active participants, and we receive funding through the Ending the HIV Collaborative, which is very important. It's EHE, Ending the HIV Epidemic work that was funded a few years back, and that has trickled down to Suffolk County as an entity. And really the work there is looking at issues of scale-up of PrEP, or pre-exposure prophylaxis. HIV testing is some of the work that's done, but certainly thinking in terms of prevention, just overall, risk awareness, condom utilization, all of the things that we know are really of critical importance in regards to HIV. So we're very active in that work across the state. And myself, I'm an HIV care provider, so and I know that you're aware of that.
Well, thank you, Doctor. I want to acknowledge public health for being the first city really in the country that did needle exchange, and for the young people there, needle exchange was very controversial in the early 80s. It was implemented under Mayor Flynn, so I want to acknowledge the Boston Public Health Commission for needle exchange, and the Boston Public Health Commission received a lot of negative feedback. A lot of it was very controversial, but the Public Health Commission really changed the conversation across the country about how we treat and provide compassionate care for people that are homeless or with substance use issues, but also supporting patients with AIDS. So thank you, Mr. Chair, for giving me an extra couple of seconds.
Thank you, Council Flynn. Council Braden, the floor is yours.
Thank you, Mr. Chair. Good morning.
Good morning.
Good to see you.
Good to see you.
Thank you for all your incredible work, and thank you for being so accessible and responsive to any calls I have. A few of the things, I really am excited about the maternal health program, the infant program. My mum was a district nurse midwife in rural Northern Ireland, and we used to have health visitors when a mother came home. Rural used to weigh the babies in the farmhouse kitchen, bring the scales and all with you. So incredible work that's really, really important, especially in an urban area where we have such incredible disparities in infant mortality. So I really am excited about that. I'm just curious about, in terms of your public health nurses that will provide some of this, how many public health nurses do you have, and what exactly, they have a broad range of roles in terms of, we've been tracking infections during COVID. Do you have enough, and are they adequately paid to be competitive in a very competitive job market in Boston?
So first of all, I share your admiration and your concern. Your admiration in that our public health nurses are critical to the work that we do, and they're critical in a number of different areas. Certainly, contact tracing, as you mentioned, during COVID, but also a lot of the work we do with directly observed therapy in terms of our TB work, which is still a major problem, particularly as we have migrants entering Boston and entering the state in general. We also manage a TB clinic in collaboration with BMC, and so our public health nurses work there. Our nurses also work in our school-based health centers, so we support 8 of them. There are others, but we support 8 of them, providing a comprehensive array of services, including from mental health to sexual risk and prevention services, treatment services, in ways that kids wouldn't necessarily feel comfortable necessarily accessing or talking to their parents about. So it's really providing a critical service. Beyond that, we also have nurses in EMS. So the number that I have, that I was informed about, was that we have 31. I need to check that number for you. So I will look back at that and get that to you after this to make sure that we have the correct number. Do we have enough? No. I just recently met with our TB clinic nurses, because we're really thinking about the fact that we have had an influx of folks with latent TB as well as active TB, and just the intensity of that work. And we have, it's it's not at the top of the list and the things that people talk about, but certainly they're doing it every day. Yeah. And one of their concerns during that meeting was that the staffing ratio is just, it's off. Okay. And morale ends up being low. So trying to get them through that's something we are working intensely with, and we're hiring a new medical director for our infectious disease bureau to work on that with me and with other leadership at the commission. So it's certainly something that we're paying attention to.
In terms of TB, do you see much drug-resistant TB? Like, I know that's a big problem in some parts of the world.
It's certainly a big problem. You know, what we're seeing is mainly sensitive Mycobacterium tuberculosis, and it's really more about informing people that this is still an issue, informing people that it's an issue that can actually kill people, you know, and keeping them on treatment for the duration of time that they need to stay on treatment. And that's a heavy lift. So I think that's key to the work that we're doing.
Yeah. I think we've talked before about the domestic violence issue. Like, I talked to District Attorney Hayden, and he told me that Alston-Brighton District 9 has the highest, one of the highest areas for domestic violence in the city, which I was very surprised at, because when I talk to the police department, I don't hear that.
Yeah.
I think that might be just a reporting issue. What are we doing in terms of prevention, in terms of domestic violence? Like, you know, I also read a very disturbing article recently about, I would call it, in the context of sexual relationships, that young people are getting into some pretty dangerous practices that are potentially lethal in terms of. So domestic violence, when it goes a step further when it's a deliberate assault, but there's also that danger of accidental asphyxiation and issues like that. What are we doing to help?
So I mentioned that we're establishing this new office, the Office of Domestic and Sexual Violence Prevention. This is a novel approach in that, one, you mentioned this issue of data. We don't have good data. It's not consistent. I've looked at some of it, more statewide than, necessarily just in the city of Boston. So one of their charges when they get in this role, it's going to be a director, and there'll be one other FTE in that office, at least to start, is really to look at the data and understand what the problems are and where the geographic locations of the problems are. We are also, working in close consultation with other, collaborators across the city. 'Cause there are lots of organizations that are working in a piecemeal, sometimes, way to do this work. The Family Justice Center is also doing this work beyond, the work that we'll be doing in this office. We're still very much so involved in thinking about, the ramifications of other types of violence, including child abuse and other situations that we know are very, very concerning. So I think that we're at the beginning stages, to be honest with you, and we'll have more to say, later on in this fiscal year as we move forward. We're very close to hiring that director, and I think we're excited about the work that we're going to do.
I'm going to see if I can get another question in before I stop. Youth programming. I think you mentioned in your presentation about drivers of violence, decreased economic mobility, opportunity, and disinvestment. I think it's a really big concern of mine that in our public housing spaces in Alston-Brighton, we've got Commonwealth Housing and Faneuil Gardens, but particularly Commonwealth Housing, that these young people, there's hundreds of kids, and we really don't have youth programming. We don't have amenities, and they're also being increasingly surrounded by luxury housing, and the disparity with their life and their experience and what other people are living life of luxury next door with swimming pools and God knows what, we're starting to see more. I think we're in a position. We're not topping the list, but we're not anywhere close to topping the list in terms of violence in Boston. But I think I'm very concerned that if we don't address this and do some preventative work and put more resources into there, that we're going to see an increased number of young people who are just disillusioned, disengaged, and going down a negative path in their choices. So I know we've got one BCYF centre that's closing right now. It's been temporarily located, and we've got one for a big district. So there's all these different levels of disinvestment in our neighbourhood that I don't know if you have any I'd love to talk to you offline to get better
Yes.
data about what's going on.
Yeah, no, absolutely. And I think if I just speak to the Boston Public Health Commission, we have a number of programs for adolescents that we would love to expand, if we had the finances to do so. We have our Youth Development Network that I know a number of you all are familiar with. We have our Boston Area Health Education Center. We have our Peer Leadership Institute, and we have Start Strong. So we have work that's ongoing and that's really critically important, that provides opportunities, a network of other peers as well as adults, mentors, folks who people can turn to. But I don't think there's probably never going to be enough, but certainly we can build on and strengthen the work that we have ongoing. And I'm just speaking about the commission. There's a lot of other things that are happening throughout the city in terms of jobs creation and what's happening at BCYF.
Good, thank you. My time's up. Thank you.
Councilman Mejia, the floor is yours.
Thank you, Chair. Good morning. Good morning. I just have to say that the work that comes out of your department, I think, is one of the most important. No, for real. Because we all often talk about the health disparities. We're always talking about public safety, and I think that the work that you do is such a central part to the public safety conversation. So public health is public safety.
Yeah.
And when I think about public safety, I also think about emotional safety, right? Because all of those things in regards to trauma, mental health, all of those things are interconnected. But it is really unfortunate when we have these budget hearings that we tend to compartmentalize this conversation. But you are such a vital part of the public safety conversation, and I'm so glad that you're making deep investments around mental health, so I'm happy to see that. I feel incredibly older. I worked with the Peer Institute like 150 years ago, and so I'm excited to know that it's still standing strong, and I'm happy to see that the Louis D. Brown Peace Institute is here, because some of the work that I did back in the day was around violence prevention.
Yes.
And the Louis D. Brown Peace Institute, the founder was a keynote speaker at a violence prevention citywide conference that I did in 1996. That's how long I've been in this game. And I'm happy to see that the Louis D. Brown Peace Institute is still very much a part of the work that you are doing as it relates to violence prevention. And so I just would love to go on the record and advocate. I know that they already are a partner. They need additional funds to support that work, because when we're talking about trauma, especially when we have lost someone to homicide, the hurt and the healing that needs to happen is part of the violence prevention strategy. So can you just talk to us a little bit about some of the outcomes that you can envision by strengthening your partnership with the Louis D. Brown Peace Institute?
So first of all, I agree and wholeheartedly support, the work that the Louis D. Brown Peace Institute has been doing with us and on their own in terms of engaging with individuals who are both impacted, affected, and suffering from the trauma related to community violence. For us, one of the big pieces of this, and we work very closely on the Community Healing and Response Network, the former NTTN, which I think is a big piece of this. And I think, we've been doing a lot of work to think about how to coordinate better and how to structure ourselves so that residents actually know what services they're going to get and know who to turn to get them, and to be visible and to be there when something happens, and not just the family, not just the victim and the victim's family, but thinking about the entire community, because that's the fear that leads to further trauma, and it may in some cases lead to aggression and depression and other mental health issues, and just not feeling safe. And you talk about emotional safety, and that's really critical. So I think the more resources we put into this work, I think the better. Even though people say, well, we're the safest city, it really is about that sense of safety, safety, security that is incredibly important as we live our lives. It's incredibly important for health and well-being. So I would just say that I fully support.
Thank you.
And I appreciate your support of this
I'm going to
effort.
be advocating for some more dollars for them, just so you know,
Wonderful.
publicly acknowledging that here. And then the other piece is the Youth Development Network. As you know, they do a lot of work with students who are chronically absent, and they fall under your commission. And I advocated for additional
Yes.
a line item to increase the pay rate for some of their case managers. And I'm just curious, as you're looking at your budget and moving forward, they were also looking to expand and to support middle school, not just high school.
Okay.
So I'm just curious, as we're thinking about prevention and intervention, I think that the earlier that we can get at young people, the better. So I just want to go on the record and saying if there's any opportunities for supports for middle school students, I'd love to see that. And then I'd love to know a little bit more now with the closure of Stewart and other potential closures. I'm curious how the Boston Public Health Commission is preparing or making any arrangements in anticipation of the influx. So I'm just curious, like, how you're going to manage that. And then, we have a lot of our newly recent arrivals, a lot of folks who are coming here carrying literally trauma in their suitcases. So they're coming here, their journey is already incredibly difficult, and then once they arrive, they have to get themselves set up for success. And I'm curious what the Boston Public Health Commission is doing to support our recent arrivals and what your capacity looks like there. And then lastly, I'm just curious about I always know that there are a lot of great nonprofit organizations that are doing amazing work, but oftentimes they're not the big wigs or the ones that have access to, networks. And I'm curious, like, what are you doing to expand? Who are the types of people that you have partnerships with? Because what I see is always the same usual suspects, and it's all in who you know. But there are a lot of small organizations that are doing really great work, but they don't have access to partnerships. So if you could talk to me about those things.
Okay, so let me start with Stewart. So first of all, I'll just say that we are in very close communication with the state DPH and EH, the executive office. They are really managing the legal aspects of what's occurring with this crisis. We are, of course, incredibly concerned of what that means for the two Stewart hospitals located in Boston, Kearny and St. Elizabeth's Hospital, and what that may mean for access to our residents. Specifically, there are concerns around emergency care and time to get people to emergency departments once if you were to, in the case of an extreme situation where there would be no longer, emergency access, what does that mean? So I think that part of what we're working on, one, is making sure we are advocating for the two hospitals to remain open, and there's no imminent plan for closure at this time. However, we are very much so spending a lot of time thinking through how we would manage access if something were to happen and what that would mean for our residents. So one piece of that is working with EMS and thinking about what does it mean for travel times and where else they would be taking patients. That's a strategic discussion. Two, it means what does it mean for patients who are just going there for outpatient care as well as like urgent care? Where else do they go? So that's conversations with the community health centers, because we have, a network of 22 community health centers. So what services can they provide in lieu of the services that are provided at those two hospitals? And then thinking about like our mayor's health line and what can we do with our community health workers and what are the strategies that we have available to us to ensure access. But right now we're telling people they should continue to access their care at those two hospitals, and we're, as I said, working very closely with the state and thinking through strategies to ensure that we have good access to care at Stewart. Okay, so the second piece you asked about the migrant crisis. Certainly the migrant crisis is an incredibly important concern for us. The way that this specifically impacts the Boston Public Health Commission is that we run the two largest adult emergency shelters in the region. Our Woods Mullen shelter is for women, and then our 112 Southampton shelter is for men. And we've seen probably about 26% of our folks who were taken care of there every night are actually migrant individuals and who are coming there, for shelter because they don't have anywhere else to go or to sleep. And what we're trying to do in collaboration with the city, in collaboration with Moya, is provide additional case management services for them, thinking about where they can go in terms of workforce development, thinking about, as you mentioned, these issues of trauma supports. That has been a challenge. We have received additional funding from EOHLC, the Executive Office of Healthy and Livable Communities, to provide some additional services. We've also expanded our square footage, if you will. So we're using the engagement center as an overnight space, which I think is really important because we don't want people on top of each other. That's also part of just making people feel welcome and feel, somewhat comfortable. So we're working very closely on this. We also do have a pilot with Moya that Moya is really leading over in the Woods Mullen shelter, working specifically with women who are migrants, of course thinking about workforce development, but all the other issues that you're referring to that are so critical to get people integrated into being a resident of Boston or wherever they go beyond that.
Thank you.
Oh, I think you also, is it time's up? Oh, okay, sorry.
Yeah.
Okay.
Councilor Fitzgerald, the floor is yours. Oh, just want to acknowledge that Councilor Durkin has also joined us.
Hi, how are you?
Councilor Fitzgerald.
Thank you, Chair, and thank you, Doctor. Thank you, Mr. Harrington, for coming before us today. I have a lot of questions. I know some might be more appropriate for the second round,
Okay.
but so I might be all over the place here. But just first, let's just start with the Stewart for a second, because I was on a call last night where we were told that there are some high-ranking officials in the state that are floating closing three of the Kearney hospitals, three of the Stewart hospitals, one of them being the Kearney. I don't know if you had heard that, but it was the first that I had heard of that last night, and so obviously that gave me some trepidation.
Do you want me to just jump in on that, or do you want to finish your question?
No. I just were you?
Yeah.
Have
so
you
it's
heard
been
that?
this has been a back and forth discussion. Quite honestly, it's been very fluid.
Okay.
And there have been discussions about closing Kearney. That's out there. It's been discussed with the Department of Public Health, with the Secretary of Health and Human Services, and with Kearney Hospital leadership. It has been discussed. What I've been told is that at least for the near term, that neither of the two hospitals would be closed. This is what I was told. And then we have to wait for as you probably are well aware, this auction process to kind of see what may happen in terms of having another operator come in and take them over. There have been discussions in that realm. And so what we are telling people, our messaging right now is continue to receive your services there. Let's support the two hospitals. The mayor's office has been involved and has spoken to people about how, we should, think about what the advocacy role of us as a city, is going to be. And we are very much so engaged. So the hope is that we'll find a solution that doesn't lead to access challenges for our residents.
And I know you guys have the ability to declare a health crisis, right?
We do, yes.
Where is that line drawn? Because I guess what I'm sort of wondering is if Stewart were to close, I think it does create a crisis, and I don't know what we have as a fallback for a city to do that.
So we, as the Boston Public Health Commission, have the ability to declare a public health emergency, with the support of our board. A public health emergency is when there is an imminent threat to health, well-being, safety, that relates to health. Mostly it's related to issues that refer to a pathogen, so a new infection, and that certainly happened with COVID-19. And the issue with doing so, and I believe that it's an important tool, but the issue with doing so is that what a public health emergency allows us to do is, in a sense, go around the systems that I think are important for us to utilize and to ensure that the public is involved in the decision making. So when you declare a public health emergency, you do not have to have the same type of robust public engagement, public involvement, these hearings. You can start making decisions without all of that involvement. So we only utilize it when it's absolutely necessary. And I think that we need to work on this issue of if there were to be, I'm saying if because like I said, this is a fluid situation, if there were to be a closure, I think that there are some other mitigating strategies that we may be able to put in place to ensure that people here in Boston still have access to healthcare. We are just, if you think about us in a broad sense as a city, we are very lucky to have the healthcare resources that we have. Yep. We have a broad network, and we need to utilize them. And I think everybody's aware that if this crisis does evolve in that way, we are going to have to mobilize all of our resources to address it.
Thank you. I'm sure we'll be talking about this much in the future, but thank you for that answer now. The Office of Domestic and Sexual Violence Prevention, awesome to see that being created. I'm wondering what is the collaboration with the Healing Response Network that you have out there? Because this is about prevention, but will it at one point incorporate sort of the outreach for the healing for it, right? Because the secondary prevention, I guess, would be part of this?
So I think that's a great question. I don't think that we are there yet in the planning. You know, we actually need to get the staff on board and do the strategic planning around what it actually looks like. My sense is that this office is not necessarily going to, at least initially in year one, be a part of direct service provision, meaning there won't be like a team that's established that goes out, at least not in year one. Yep. I think this is really going to be about policy planning, data, understanding the problem. As I mentioned to Councilor Breeden, I don't think we have a good understanding of that at this time. And I would love to, once we have some data, bring it back to you and we say, okay, so what is it that we should be doing here that's different to address these issues of domestic and sexual violence?
Thank you. Also, not sure if this falls in this afternoon's or this morning, so I'll just ask it. In the addiction response resources, the Community Syringe Redemption Program that you guys, I don't know how much we fund of that, or if that's 100%, or is that just something that we give money to, or if that is a Boston Public Health Commission program
Tim, can
itself.
you just talk about that?
Yeah, sure. So that's been funded by APRA the last several years.
Yeah.
And I think the game plan for that going forward is potentially to use some of the opioid funding settlement dollars to keep that going. There's no question that's a paramount priority for the city. So we know we want to keep that going. And as of right now, we're leaning towards using the opioid settlement funding for that program over the next sort of several years.
I believe, though, would there still be a decrease in their line item budget? Because I've been told they've with the potential as of May 10th, they'd have to go from 5 days a week down to 4 days a week. And I wonder where that cut's coming from, and if we plan to fund it back up to 5 days? Because I know over the last year they've collected 1.8 million needles from about 3 different locations. Obviously, the majority being Mass and Cass in my district, District 3. And so I would prefer not to see any reduction in those services, also being the ones that we as the city and the Boston Public Health Commission provide a lot of those needles, right? So I would want to see us provide more, but then pick up less.
So if I could jump in for 1 second, then I'll let Tim respond. I think that one of the ways that we're approaching interventions like CSRP is really looking at the services that provided and evaluating them and seeing what is it that we're doing. Is it exactly, what we want to be doing for people living with substance use disorder and for the city? Because there's a twofold response, there's a twofold strategy here, right? So you're picking up needles, but then you're also engaging people for many people on a daily basis. And are you providing them services? So we're actually speaking with them. They are good partners with us. We're trying to get a sense of the program. Can we, build it and make it stronger in the process? So we're not, our intention here is not to reel in or decrease the service provision. It really is to actually ultimately strengthen it. But we need to understand what's happening and what we could be doing better within the context of the program. So I would just say that taking away that 1 day is actually giving us a better sense of what we are doing on a daily basis and what we may be missing without that day and what we may not be missing without that day. So it really is evaluation and understanding how we improve the program and the services within your district and ensure that there is needle pickup, but there's also service provision to those individuals who are engaging in that program.
Great. Thank you. Yeah, I would definitely like to be kept, that data going forward with that one less day.
Yep.
And also just, I'll hear from the community, I'm sure, right? Just a quick one, because I know I'm done, but Mayor's Youth Council, just thinking about all the health initiatives that you guys are doing around young families, kids, teenagers, and all the mental health. Is there a collaboration you have with them to help them get out the word to their folks at their high schools and things like that? I only speak as an alumni of the Mayor's Youth Council back when I was in high school. And it's grown much larger since then.
That's great.
And so I always found that even when I was on it, we'd always collaborate with the department. And I feel that you guys have a lot to offer in terms of at least the mental health and a lot of what kids in high school are going through these days.
100%. I would need to check in with our leadership of our Child, Adolescent, and Family Health Bureau. I'm sure that there are connections, and I'm sure that we are disseminating information, but I don't have an exact answer for you. But if there's not a connection, then we'll make it happen.
That was just an idea to throw out there at the end. But thank you very much for your time. Thank you, Chair.
Thank you. Councilor Weber, the floor is yours.
Thank you, Chair. Thank you for everything you're doing for the city and your speaking to us today. So I had a question following up on Councilor Braden's comment about Public Health Commission nurses. I think you said there are about 31.
Yes, this is the estimate that I've gotten. Like I said, I would like to provide you with an exact number after this.
And the nurses are, they're coordinating with schools and other
So we have
institutions?
school-based nurses. We have nurses within our infectious disease bureau, and many of them are doing contact tracing, follow-up of cases of positive, like if somebody has latent TB. And they're also working in direct service provision within our TB clinic. And then we have nurses within EMS.
Okay. And I guess, so a constituent reached out to me, it seems that the nurses are in a bargaining unit. It's a SEIU 1199.
Yeah, 1199.
They've been without a contract for three years.
Mm-hmm.
Is that accurate?
That is accurate.
Okay. And so I guess, what is do you have, any updates for us, or do you see any movement coming soon? Because it sounds like it's a highly valued group. And
Absolutely.
So I don't know what you can tell us about when you expect a contract. Obviously, it takes two to tango in that respect, but I'm just interested in your side.
Absolutely, and again, I mentioned this before, that we, leadership at the Boston Public Health Commission, 100% support and want to uplift our public health nurses. The work that they do is invaluable to the city. Our labor and employee relations lead is working with the cities, and they are in ongoing negotiations. Unfortunately, I don't have much that I can really share in regards to those discussions at this time. But again, we 100% support their work.
Okay, and I'm just looking at your responses to the RFI. And we asked how many, list some positions that have been vacant for longer than 6 months, and I see two public health nurse listings there. I mean, is it true that the Public Health Commission nurses get paid less than other nurses in the city, or?
Yes.
Okay.
Yeah, I'm a physician at in MGB, and I know that they get paid less. Public health nurses in general across the country get paid less than those who are in your academic hospitals and in that sort of setting.
Okay, and then with the ones that work for the city, there's a residency requirement. They have to live here. Has that been an obstacle in filling these positions, or
So, but let me answer your question. I just got information. It's actually 30 public. So I was close, but not quite. So, in terms of the residency requirement, which we adhere to, I think that for all of our staff, having to live in a place like Boston, which is extremely high priced in regards to rents and mortgages is a challenge. I mean, it's something that we struggle with across the board in terms of our staffing. So it is a concern. I am a strong believer in wanting to retain our workforce, which is a challenge. And it's something that I think across the divisions we're struggling with, and certainly in areas like the Boston Public Health Commission, where we know that there's other competition for staff, that is a major issue for us. Yeah. But whatever you could do to help, I think we do great work, and I think that people enjoy, working for the Boston Public Health Commission. I think we've tried to support our staff in many different ways and increase morale. So I think, we'll continue to work on it.
Okay. Yeah, no, I think the residency requirement, coupled with the fact that there, I guess, haven't been any wage increases at least in the last 3 years. Has that made it hard to fill these positions, and why we're seeing openings? So, okay. Well, as a comment, I would love to see the administration and SEIU 1189 work out this issue and support our public health nurses. Does the Public Health Commission employ contact tracers?
Right. So when we were engaged with COVID-19, of course, our public health, our infectious disease bureau had contact tracers. Our public health nurses were very much so involved from the very beginning of the COVID-19 pandemic. In regards to TB, that's another area where we do a lot of outreach and think about contact and ongoing testing and those sorts of needs.
Okay, yeah, I thought one of the lessons of the COVID pandemic was that the contact tracing did not provide the sort of ability to slow things down or treat it. I don't know how contact tracing is being viewed as in the future.
Right. So I think contact tracing as a strategy is really depending on the pathogen. What is it that we're talking about? So with COVID-19, just the fast rate that people were becoming infected, it wasn't so useful. I mean, in retrospect, in some of the studies that you're referring to, it did come out that wasn't the case. But I was letting you know, though, that we did have contact tracers, and we did have people who were following up with folks to make sure they remained isolated, because that was another piece of the initial 2020 sort of response. In terms of TB, we're talking about something that's very different, different pathogen. So I think it just really depends on the scenario.
Okay. And you mentioned needle exchanges, and so we have there's the cottages at the Shattuck Hospital. Those are closing soon, but what was your involvement? I mean, there was stories of needles in the park around the cottages. I know the Shattuck is a state facility, but the park is ours. What was your involvement with that?
So we, in partnership with the state as well as with other partners, initially it was BMC, but other service providers led the establishment of these 6 low threshold sites. And one of them is the cottages, and it will be closing at the end of June, as you're probably aware. I think that the issue of services that were provided there, I think was incredibly important to have harm reduction, because those are people who are, ongoing and active individuals who are using drugs. And we, as Councilor Flynn mentioned, have been a forerunning city in terms of decreasing our risk and rate of all sorts of communicable diseases. So it's really been critical that we have harm reduction and that we have our syringe services programming and our harm reduction kits. So that's been a big deal, very important. We also have a really robust needle pickup service. So our mobile sharps sort of team that goes out and picks up needles across the city, in the Shattuck area, of course, but of course at all the different parks. And I think that that's been a key focus, because obviously that impacts residents, and we don't want there to be ongoing transmission and needle sticks or anything of that nature. So it has been something that we've invested a lot of money in, and I think it's been rather important. With the cottages closing, we'll obviously see what occurs from there, but the program will continue.
Okay, thank you. Thank you, Chair.
Thank you. Councilor Murphy, the floor is yours.
Thank you, Chair.
Thank you for being here. It's been said, but we can't understate the importance of our physical and mental health and how it affects every other department. So I agree that, we could argue many departments, but you're probably the most important and working alongside all of the other departments. I know from being a teacher, kids aren't going to learn if they don't feel safe, if they're not healthy, if they're not mentally healthy. So just wanted to thank you for your work there. I have a few questions. I'll just say them all, and then if we get to them, that'd be great. And some of them are just comments, but we know things shift. In the last 2 years, there was a lot of focus, and there was time and resources spent on COVID-19 and mass and CAS, obviously. And as we're kind of coming out of those, and we know that the mass and CAS issue isn't gone, but it's spread. Could you list like the top 3 populations and the top 3 health issues that you feel you're focusing on? Some things that come to mind from me personally in my office that we hear is like grandparents raising grandchildren. I always think we need to uplift and focus on our 18 to 25-year-old population and homeless women. So those are just some of the thoughts I have. We spoke about Steward. Thank you for that update. If you could touch or speak to the importance of making sure our health centers and how important of a role they do play in our city for the health and security of our health centers going forward, because that's something we can do on this body, advocating to make sure our health centers are supported. And if you could share the conversations that you had that brought you to the decision to create the domestic violence sexual department. Is that the official name you're calling it? Because I know we debated last term on the council of whether or not to have a standalone domestic violence committee, which is something, I can assume that many of the conversations were surrounded around, focused around knowing that it's a specific population with very different needs, so a different focus. But if you could touch on that, that'd be helpful. How are our homeless shelters doing? I know in the city we house individuals, the state houses families, but you talked about the cottages coming to an end. We know that there was deadlines also on our migrant families, and I know you were very involved in those needs also. So what happens, right, when the date comes, and what are we doing as a city to support? And lastly, this whole cliff spending fair that we have with the school department money, but also the opera funds. You mentioned that you're using something, that you were spending opera funds on the syringe pickups, and now we're using opioid money. What else were we spending opera funds on that could potentially be a concern going forward? Like, what do we need to step in and make sure we're funding separately? And just probably a good explanation, but the first thing that came to mind with opioid settlement, that opioids aren't directly connected to needle syringes. So what made you decide to use the money for that? I know it's like substance use is substance use, but it's a very different type, so what?
Okay, sure.
Yeah.
No,
So those are,
absolutely. Okay. Before I get started, if I could just go back to school for nurses for 1 second, Councilor Murphy, just because I don't want to leave out anyone. We do have nurses within our Healthy Baby, Healthy Child program too. I apologize, I didn't say that. I said school-based nurses within CAF, but it's also within Healthy Baby, Healthy Child. They do play a crucial role in terms of those home visits. So I just want to make sure that that's on the record, that we also have them in that space. Okay, so you asked a number of questions. I'll start with, you asked about sort of our top 3 populations. So I have to be honest, I have a hard time narrowing it to 3. Certainly,
probably more.
Certainly individuals living with substance use disorder, given that this is a crisis, given the impact that it has on premature mortality within our city, number 1 cause from 2017 to 2021. Clearly that is a focus of a lot of our work. Unsheltered individuals, homeless individuals, irrespective of substance use disorder, certainly that is an ongoing concern. Making sure that we have space somewhere for them to go, I think is critical, particularly as we think about summer coming and what we've already seen around our streets. It's something that we're having ongoing meetings about. the migrant population, given the influx into our city and what's happening at our shelters. As I mentioned, about 26% of our adult shelters are comprised of migrant individuals, folks seeking asylum, looking for a better place, looking to start a life. So certainly they are a major concern, but that's not to the exclusion of the other people in our shelters, some of whom have been there for a very long time, some of whom are elderly and who just, that's their home, and it's like, well, where are we going to place them, and what services could we provide for them to move on and get into a better circumstance for themselves. I would also say, we have this challenge with our infant mortality rate and our maternal morbidity and particularly morbidity, not mortality. The numbers are lower in Boston, but morbidity and then infant mortality, major concern here in Boston and any urban center across the U.S., particularly given the fact that we put so much effort into this work. We put so much effort into Healthy Baby, Healthy Child. It's a program that's done incredibly important work for the last 30 years. But then the question is, so what do we need to do differently to sort this problem out? And that's what we're thinking about. And that's why we say, let's do this fetal infant mortality review and actually understand what the challenges are. Let's look at home visiting services. Let's start the doula program. Let's enhance that. And we've been able to do that with grant funding.
What are the numbers like?
For our infant mortality rate.
in
So it's overall, I believe it's 4.6 per 1,000 live births. For Black individuals, it's 9.7. For white, it's 3.2. So there's clearly a different, there's a significant difference that I think is incredibly important. Children, just in general, huge concerns there about a lot of the things that you all have already spoken about, a lot of the work that's being done within the Child, Adolescent, Family Health Bureau. We're doing a lot of work for the younger children. We're doing a lot of work for adolescents. Is there more work that we can do just across the span for kids, and thinking about both prevention and for addressing ongoing needs, particularly around mental health, which is why we have the youth mental health work. So that's the list that I would say right now, but certainly is not exclusive, and I don't want anybody to feel that the Boston Public Health Commission is not paying attention to their needs. You mentioned the role of CHCs. So our 22 community health centers they're incredibly important to the work that we do. A lot of what we're doing in partnership as we think about inequity is working very directly with them. We do fund them annually. We fund not all of them, but many of them. And we have topped it off with ARPA funds. Last year, I believe we put out an RFP and are funding a number of them to do critical work to enhance services, to think about deferred care, to really engage people in care. So our CHCs are quite important. They do a lot of work with social determinants of health, obviously, right? Mm-hmm. They do it on an individual level, and we do it on a more of a population level. So connecting the dots with those pieces, I think, is incredibly important. You mentioned the discussions around domestic and sexual violence prevention and the establishment of the office. So some of what we were thinking about related to discussions with city councilors, obviously. You all highlighted the issue, said it's important, said we can't just look at penetrative violence, we have to think about other forms of violence. Also, this work was with the Family Justice Center, and like what it is that they're doing and how can we augment that and think about the ramifications and the spectrum, I shouldn't say spectrum, the continuum of violence that occurs, from what happens in families and child abuse and domestic and sexual violence and all of that, together. How do we do a better job? And I think that's part of the collection of data and thinking about strategic initiatives. Let me turn it to Tim to talk about the ARPA funds.
Yeah, so as far as the cliff goes, over the last couple years, we've been using ARPA primarily for the mass and cast response. And it's these sort of 5 or 6 different buckets, the syringe redemption program, storage for our homeless clients in the area, workforce development, that's through the contract with New Market with Sue Sullivan, transportation, and then overnight techs at 112. So, that's all been up in the last 2 years. That funding is ending for those buckets of funding at the end of this particular fiscal year. So we've been having our discussions around, how we can continue those services for the mass and cast response, because we definitely, we certainly need to continue those for another year, potentially another couple of years. And we have that, right now we're looking at $10 or $11 million of opioid funding, settlement money, and I think that seems to make the most sense to use that because it's such a critical response, and as of right now, we don't have any other sort of funding source for that.
Okay. Thank you. Thank you, Doctor.
Thank you. Councilor Durkin, the floor is yours.
Thank you so much, Chair, and really appreciate our new timer. This is great. And thank you so much, Dr. Vizolo-Jakutu, for all of your work. I'm really honored to work in partnership with you. Wanted to ask a little bit about the coordinated response team. They do a great job in our district. That is underneath your auspices, right?
So the coordinated response team is actually in the mayor's office, led by Michaela and Brian, who you probably know well. We work in concert with them. Our street outreach, our red shirts, our street outreach team works with them as we have posts sort of dismantling the encampments, kind of going around the city and engaging people.
That's helpful. Thank you so much. And was just curious about some of the coordination with, and maybe this is still a helpful question, some of the coordination with groups in, in my district, the Downtown North Business Association, the Back Bay Association, NAB, Fenway has a Communicate and Connect, the Beacon Hill Business Association are all groups that work on homelessness in my district. And just curious sort of what kind of coordination happens with communities. And it does seem like a lot of that is the coordinated response team. But if you could give some more sort of flavor into like how exactly that works and what is the best way for a community to advocate for our communities.
So I can speak in general. We meet with the CRT once weekly, and that's my team as well as myself as often as I'm able to do so. And much of what they're doing is communicating with them and giving them information, feedback. Where are we seeing groups of people congregate? What challenges are businesses facing in that regard? I mean, if you think about, challenges related to, use of facilities, use of bathrooms, that sort of thing, overdoses. But I also think a piece of that we've been working on with businesses and with our own community engagement teams and with our Red Shirt team has been teaching businesses and teaching community groups how to use Narcan, naloxone, right? So how to recognize an overdose and then how to actually, reverse it. And thinking about harm reduction, even though that may not be, philosophically aligned with everyone, just understanding it. So I think decreasing stigma, increasing awareness, increasing education about how to manage overdoses is incredibly important, and that's part of what we all do.
And just following that line, a lot of BU students, they are in the middle of, some of them are in the middle of a strike, others of them are thinking about striking. And I was just curious, one of the things that is on their list in bargaining is they want to be trained to use Narcan and they want to be able to access those resources. And I just think that shows how thoughtful some of these students are and like wanting to be there for their communities. Just curious, what resources are available to regular citizens who want to be trained in the use of Narcan and how accessible those resources are.
So our Recovery Services Bureau does offer training. Those are in person and online. I don't have like a schedule, but certainly if there are groups that you're interested in working with, you can just reach out to me, and we can try to coordinate something. I wish there were more resources and more people. Most of our team leads who conduct the training, they're out on the street. You'll see them roaming around, doing that sort of work during the day. But certainly we can look into expanding our work in that area. And the other thing that we're doing that I think is important is with some of our funds from the CDC is we are expanding access to naloxone through vending machines. Which I think is a thing that's been happening across the country. That in and of itself will provide accessibility, and it will offer some level of basic training. I mean, using naloxone is not difficult. It's just you feeling comfortable doing it. So that will provide that access, and I think that's an important way to expand that role. The other thing that we're doing with our opioid settlement funds is that we are funding community-based organizations, particularly in neighborhoods where we've seen an uptick in overdoses, to do naloxone training. So there'll be more available, do training on overdose prevention, and to expand access to naloxone.
Thank you. And wanted to get into something about, I know this is a way longer subject, but about Long Island. I know that the I know that the city council and the mayor did take a trip before I was on the council, and I just wanted to ask sort of what conversations are taking place. I know that we've had some wins in court around, being able to, and obviously I maybe I didn't overlooked it, but I didn't see anything in the capital budget. So I'm just curious sort of what conversations are taking place. And then my second question, just because I know I'm running out of time, is I know that you have an IGR department, and that's both to work with us, but also to do state advocacy. Curious what state advocacy is happening at the State House around public health and what we're fighting for. And sorry, just following up on the Long Island, could we do a tour as a city council, and is that something that we would coordinate with you or the mayor's office?
Okay, so in regards to Long Island, an appeal is ongoing, so it's pending, and that's an appeal of the Massachusetts Department of Environmental Protection approval of the bridge project. I don't have a timeline on that right now. However, while we are in this sort of pending status, we've been working with consultants who are thinking through what operations, what services could be available on the island. It's a bit of a process, one, because of just distance from the mainland, and thinking through how we can shore up the continuum of care longer term for residents of Boston and for the region, because it would be a regional resource. So that's what's going on now. There will likely be a report and a meeting with the mayor, and certainly a meeting with city councilors soon. I don't have a date yet for that, but that's been an ongoing process.
No, I know. And, it's just something that I think sometimes things are out of sight, but they can't be out of mind, because we do have unique opportunities as a city to deliver for folks who are facing, homelessness and in need of recovery services. So I'm a big proponent of just having that conversation out in the open, because it is a unique resource, and we do have a unique opportunity, I believe, to be moving in the right direction. So it looks like I'm out of time. Okay.
Thank you. Get my questions. Thank you for your service, all your work, and always being responsive. Wait, yeah.
Oh, sorry,
Second.
I did ask another question I forgot about state advocacy at the State House with IGR.
Yeah, we'll come back to that on the second
Okay.
round. On page 12 on the RFI, it shows that the BPHC is receiving an $8.9 million public health infrastructure grant from the CDC. Is there any explanation on the breakdown of how those funds will be allocated?
Tim, do you want to start?
I don't have the total numbers in front of me right now.
Okay, yeah, you can submit that to the,
Yeah.
to me.
If I could just say a couple things. So
Yeah.
a lot of the work there, that public health infrastructure grant's a 5-year grant. And a
Okay.
lot of it is about professional development, really shoring up our infrastructure, thinking through strategies for retention,
Right.
and ensuring that we have a stronger public health workforce, as we've had a lot of attrition and, as you know, vacancies.
Right.
So we're really trying to build a workforce for the future with that money. We're in year 2 of that grant, so it's just sort of getting ramped up. We've also hired a chief people officer, which is really the person who is leading a lot of that in terms of, sort of increasing how we think and shore up our staff morale, and think about all the human resource needs that we know are present within our agency.
Awesome. Speaking of training, I like the training and capacity building on the violence prevention. I would like every resident, if possible, to be educated on violence prevention and trauma strategies. Can you talk to me, are these annual trainings that are taking place in the community, or just for City Hall employees? Or?
So my understanding of CBTI, the Capacity Building Training Institute, is that a lot of that work is really based on what the needs are within programs. This was a new initiative to work with city councilors, and it was something you all had mentioned, and we thought was a great idea, and we'd like to do more of, to meet with staff as well as you about trauma, about resilience, about how to manage these issues with constituents. So we would love to see it expand further across departments.
Awesome, love that. In 2022, BPDA reported or cited 2 buildings in Mattapan on campuses that were ready to be demolished or underutilized. Can you talk to me about the process for studying how to, I think the BPDA report cited the exploration of using housing on these sites. Can you talk to me about that process and where you at in that timeline?
Tim, did you want to start, or do you want me to?
I mean, I could start, and I can talk briefly about the property out
Yeah.
there in Mattapan. So the city, the Public Facilities Department, they're going to do an assessment of all of the Health Commission's building and the city's buildings over the next sort of 12 to 18 months. And BPHC is going to be kind of one of the earlier groups to be part of that. So we're working with Public Facilities to do sort of an updated building assessment of all of Mattapan, Northampton Square, the Finland Building, all of our properties. And then just generally, we've had some conversations about further uses of the Mattapan campus, both for BPHC purposes and then for, whether or not we wanted to use it for additional housing for residents in the city. There's, that's a priority. Then there's, obviously, different priorities that we have for, sort of more permanent, housing for folks who are in our low threshold spaces, and then potentially moving into something else like that. So we haven't made any final decisions about that, but if you wanted to add anything else to that.
No, I know we've discussed this with you, Councilor Worrell. We're certainly discussing with BHA. There's obviously a need for housing. There's also a need for expansion of BPHC services out there. We have transitional housing for people who have entered recovery. Could we do a mixed sort of a setup where there's space for a lot of different programming as well as housing? I think that's certainly something that we're considering and would like to continue to discuss.
Awesome. And then the community-led response RFP. It talks about community-led response team with a focus on mental health as a third pilot program. Can you talk to me about the other pilot programs that have happened, and if there's any report of your findings on those other two pilot programs, and then just kind of hearing your vision on what you hope to achieve out of this third pilot program?
Sure. So the community-led response program is an initiative to essentially figure out ways to remove the public safety, the police response in issues that are related to mental and behavioral health. We've had a lot of community engagement in this process, and as you know, this has been going on for quite a while now. There is money set aside in the budget to move forward with a pilot. So right now, what we have is an RFI that's out there, so a request for information, to essentially find a community group that would be willing to do this work, and help us design a better system, just because there wasn't a good understanding of who could do it best. So once we get that information, and I think the RFI closes at the end of May, so in a couple weeks, then we will pull that together, bring our key stakeholders together to discuss it, and then develop an RFP for that particular pilot that will hopefully move forward towards the end of the year, I'm estimating. As I said, I think this has been an extended process, but I think it's been good in that it really truly has engaged community in designing what they think would be best as we think about how to better treat people who are in crisis.
And are there any other cities that have this model that you'll point to as a?
So I think that's a great question. I don't have a city in mind, to be honest, Councilor Worrell, but I can get back to you on that.
And then one of the major complaints I get from my constituents is noise, and I see that you guys have now taken on the noise ordinance. How has that been going? What's your coordination like with Boston Police?
So our office is receiving an average of 8 complaints per week about potential violations of the Boston noise ordinance. We basically have a system where we get these from the 311 system, and we address them accordingly. Obviously, we think that this is an incredible problem within any urban center. I would say that probably 30% are issues that we can address directly, so noise from like mechanical ventilation systems or similar sort of sources, while the remaining are related to loud parties, alarms, train noises, other things that we don't we can't, as a BPHC, necessarily manage, but certainly in a lot of cases, BPD is involved. So I think it's an ongoing issue, an ongoing concern. We do have, I think, the right inputs in terms of FTEs who are involved in this.
All right, thank you. We'll now move forward with public testimony. When your name is called, please come down to one of the two podiums, right there or to my right. Please state your name, neighborhood, and/or organization affiliation. Please speak into the microphone, and please keep your comments to 2 minutes. Starting off with Rachel.
Good afternoon. Thank you, Chairman Worrell and members of this Ways and Means Committee. Thank you, Dr. Ojikutu, for your partnership and leadership. And thanks for the opportunity to testify this afternoon. My name is Rachel Rodriguez, and I speak today as one of the co-executive directors of the Louis D. Brown Peace Institute. The Louis D. Brown Peace Institute is a Boston-based organization dedicated to supporting families and communities impacted by murder, trauma, grief, and loss, and fostering peace within the city of Boston. For the last 3 decades, the Peace Institute has served as the cornerstone of the city of Boston's homicide response. Agencies began referring survivors of homicide victims to the Peace Institute for support in the aftermath of a homicide, while the Peace Institute quickly became the holder of families in their loss. The Peace Institute proceeded to also organize and mobilize a network of providers across practices to better coordinate services amongst stakeholders involved in a family's case. The Peace Institute would train these providers in best practices when serving survivors of homicide victims, and we continue to do so today with the now existing infrastructure of responders. It's clear that within our tenure, the Peace Institute has risen to the occasion and has taken on our role willingly and with great strength and vision. We're very proud partners with the Boston Public Health Commission and the Community Healing Response Network, formerly the Neighborhood Trauma Team. As we expressed in previous Ways and Means Committee hearings regarding the city's FY25 budget, the Peace Institute is advocating for a 3-year funding commitment of $1 million annually. We've proposed that this $1 million of funding is spread across 3 city departments. And for the purposes of this hearing, I'll just focus my remarks on the $350,000 that we propose come from the Boston Public Health Commission. Mayor Wu has publicly stated that the Peace Institute is part of the infrastructure of the City of Boston's homicide response, and we're respectfully asking for the funding that reflects that. Relative to today's hearing, we ask that the Boston Public Health Commission funding designated to the Peace Institute be increased from $100,000 to $350,000. We respectfully ask the City Council to amend the mayor's budget to include this allocation. Much of this would go towards our own staff development. And we've submitted a letter in writing to the council via email that further outlines the details of the budget request for FY25. I'm happy to address any questions today or in follow-up. Thank you so much for the opportunity to speak with you today.
Thank you. Willow?
Okay, good afternoon, and thank you. You'll have to forgive me. I'm going to be using all of my extrovert energy to address you today. My name is Willow Osgood, and I'm a family nurse practitioner, and I work in the school-based health program at the Boston Public Health Commission. I work at the Burke in Dorchester, and I live in Jamaica Plain. Now, I just want to share a little bit about the work we do, because when most people hear about school health, they immediately think of the school nurse. And while we collaborate and share many of the same goals as school nurses, we occupy a unique space and meet a need that's unmet by school nursing. So, for example, as a nurse practitioner, a student has a sore throat, they come down, I see them, I'm able to administer a strep test. If it's positive, I'm able to send a prescription, I'm able to communicate with their parents, and it means, bottom line, that kids stay in classes more, parents stay at work longer, and that the kids get the care that they receive. I also see a lot of kids for sports physicals, and what this means is that if they have a 4-month wait at their primary care, that they're not benched for the season. And lastly, I see a lot of students for confidential sexual and reproductive health visits. So we do everything from Plan B to inserting Nexplanons. We do STI testing, education, and treatment. We also empower high school students to take care of their health. We counsel them on sleep, on food choices, relationship choices. We build health literacy. We connect them to mass health, refer them to specialty care. We empower them with the tools to navigate the health system and advocate for themselves as they grow into adults. Our patients are among the most vulnerable. They are students in foster care, recent immigrants, and refugees without social connection. And to Councilor Mejia's question, I've seen about 12 refugees this year. They're student athletes who dream of attending colleges. All right, that's my 2 minutes, so I'll just skip ahead a little bit. I'm here with a lot of nurses from Healthy Baby, Healthy Child. I love the work that we do, and it's just simply, thank you. It's mostly nerves, like I said, not enough extrovert energy. So there are many vacancies currently, and our programs are suffering as a result. So I'm at Burke, but I'm also at Madison Park. That is a vacancy that has been in place for over 6 months. Healthy Baby, Healthy Child also has vacancies. We are not adequately compensated, to Councilor Breeden's point. It's not that we don't make as much as MGH or BMC, it's that if I took a job with BPS nursing, I would make more than them doing that. So let me just close up. I know that I did my 2 minutes. In Boston, we know that life expectancy is dramatically different based on zip code and race. We are one city, but it doesn't always feel that way. School-based health targets communities most in need. We are meeting the moment and are on the front lines of fighting health inequity and fighting for racial justice. We ask you today for your continued support in this work. Thank you.
Thank you. Emmy?
Is this one working? Yes. Okay.
Yes.
Good morning, Committee Chair Worrell and members of the Ways and Means Committee and other members of the City Council here present, Dr. Ojikutu and your team at Boston Public Health Commission as well. My name is Amy Takanami. I'm a resident in District 6, a social worker, and a steering committee member of the Mental Health Crisis Response Campaign, here with other members of our campaign right here behind me, many of who also couldn't be here today due to timing of this hearing. And we're here to share testimony in support of fully funding the pilot for the non-police, non-carceral, community-based mental health crisis response model at $2.6 million with funds diverted from the Boston Police Department, which is proposed to see a $50 million budget increase. I want to take my time to highlight 2 ways our model is distinct from the current alternative crisis responses that are currently available in the city, namely co-response models and EMT and social worker models. The first is that co-response models still include the police, and hence still escalate crises, particularly for historically most marginalized communities, such as BIPOC, queer and trans, disabled, immigrant, and working class people. And the statistics support our experiences as well. A person with unmet mental health needs is 16 times more likely to be killed by the police. Co-response models reinforce the idea that people in crisis are potentially criminal and dangerous. Secondly, in regards to EMTs and social workers, they are both mandated reporters, meaning while they are technically non-police, they are still carceral in that they can trigger a carceral response at any time, including police involvement. Mandated reporting also escalates crises by decreasing trust and increasing people's interactions with the police, often ending in criminalizing people who are seeking support and deterring people from reaching out for help in the future. Our model fills a current gap in city services and would allow community members access to a fully non-police, non-carceral, community-based response to crisis, which we believe will promote genuine public health and safety for all, and in particular, for those most impacted by the harmful role of policing and carceral practices that are unfortunately present in all of our other current available city responses. Thank you for this time this morning, and I urge you to support fully funding the pilot for this model at $2.6 million with funds diverted from the Boston Police Department.
Thank you. Mikhail?
Hi, my name is McKaylee, and I'm a youth participant at the City Schools Pathways to Change, and I'm a freshman at UMass Boston, and I'm also a resident in Rosendale. I'm here asking that $2.6 million to be defunded from the police department and reinvested into a pilot of the mental health crisis response, which is a totally consent-based and non-carceral response. The team of responders will consist of community members who are trained to support people in de-escalating mental health crises. This being non-carceral is very important to us because police tend to escalate situations that most times, the people just need to be talked down when going through a crisis. What's best about the mental health crisis response is that if someone doesn't feel comfortable talking to their parents or a counselor at school for support, they could call the mental health crisis response and it will connect them with an experienced community member who is able to help them confidentially with anything they need, whether that be a phone call or a house visit. As someone myself who's gone through mental health crises in the past, I feel like this pilot would be helpful because it gives me, not just me, but other people the ability to open up to someone in a way they feel more comfortable because it is confidential. I believe that a lot of people hold back from asking for help or being honest with the help that they need and fear that they will have the police called on them. So when we have a safe hotline like this, they know it's confidential and consent-based. It gives them the peace of mind to seek support whenever they want to. I hope you will support our pilot, and I'm confident that once this is up and running, this will be something that is vital to our communities. This will give people who feel like they have to suffer in silence a safe place to let their voices be heard, however they feel comfortable to do so. I hope you take this in consideration, and thank you for your time.
Thank you. Maya?
Hi, everyone. My name is Maya Millet-Strickguy. I'm a Boston resident and on the steering committee that facilitated the design process of the community-based mental health crisis response model. I'm here, along with this crew behind me, to also uplift the ask for $2.6 million divested from the police for the pilot of this model. I want to share from my perspective as a licensed clinical social worker who's worked in the field for 10 plus years, many years of which have been doing community-based and in-home work. I've worked with many folks navigating mental health crises, and I both witnessed and heard countless times about the harms of our current response system, including both the police and the BEST team. Responding with guns and badges only escalates a crisis and further traumatizes someone. The BEST team frequently calls the police, so the city's work to increase coordination between EMS and the BEST team as a quote-unquote alternative model is not actually anything much different than the harmful responses we already have. Community members who are most at risk of the harms and violence of a police response would still be at risk. Even when the BEST team does not involve the police, they still often engage in non-consensual practices, including forced hospitalization. This practice is re-traumatizing, akin to imprisonment, and research demonstrates that forced hospitalization increases, not decreases, suicidal attempts and ideation. The community-based model would not involve law enforcement and was designed and prioritizes communities who are most impacted by the current police response model. A core value anchoring the model is that it is consent-based, trained community members who would be trained in de-escalation and responding to mental health crises, among additional trainings, who would be responding to other community members in crisis, would focus on providing the care that someone needs and consents to in a moment of crisis, as opposed to prioritizing, honestly, liability concerns, as many BEST team responders do. We are asking for a fraction of even the $50 million proposed BPD increase, let alone compared to the full BPD budget. Lastly, to Councilor Worrell's question, as is detailed in the official city-funded report that we submitted to Mayor Wu's office and the BPHC, there are a number of non-police, community-based mental health crisis response programs that have decreased arrest rates and saved money for cities across the country, from Denver and Oakland to Eugene, Oregon. Please put $2.6 million in the FY25 budget towards the pilot for the community-based mental health crisis response model. Thank you for hearing testimony today.
Thank you. Darian?
Hello, my name is Darian Alexander Williams. I'm a professor at the Boston University School of Social Work. I'm a resident of the South End, and I ask that you allocate the $2.6 million from the Boston Police Department for this pilot program for a community-led, non-carceral, and consent-based mental health crisis response. Research shows that in many mental health episodes, police involvement, even their presence, can be unnecessary and even harmful, and this proposed pilot program emphasizes deep engagement, effective support instead of use of coercion and force, and it must be robustly funded to be effective. In addition to being a social work professor familiar with the research on this subject, I'm a member of a family that has had numerous negative and dangerous interactions with law enforcement during mental health episodes. I've also worked as a campus staff member supporting college students navigating emergency mental health challenges in their housing. I've had to call 911 in both of these cases, and in both cases, I really wish that I didn't have to hesitate and wonder if the help I was calling for would lead to my loved ones or my students' death. I urge you to consider this pilot program. I urge you to consider robustly funding it. I hope you support this. It will immediately and positively impact our community, reduce harm, and foster a supportive environment for all members of our Boston community navigating mental health challenges, and those of us who love folks who chronically deal with the carceral state and mental health institutions. Thank you for considering. Thank you for listening.
Thank you. Hafsha?
Hi, my name is Hafsa, and I go to Brighton High School, and I work at the city school as emerging leader where we fight for social justice and people's rights. I'm 18 years old, and I live in Dorchester. So I'm here to fight for $2.6 million in the budget, taking from in law enforcement for non-carceral mental health crisis response. The mental health crisis response model is helping people meet their needs when they're going through depression or other things. They need someone to help them with mental health crisis response and support them. Most of the people who are fighting for this model are young people, people from community, disabled people, low-income people, immigrants, and people of color. This model is all free, and there will be no charge to call. You'd be just to call a number, and there will be a trained person who would be ready to come support you. There are many young people and adults who are scared of police. The way they act can be scary because they have guns. Those youth and adults don't want to talk about what they're feeling and the things they're going through because they're scared and nervous at the police. If there's someone to support you that it doesn't involve police, they are going to feel more comfortable to share how they're feeling and get the help in that situation. So I want you to support us. What are you fighting for? $2.6 million in the budget for community based on mental health crisis response. Thank you for listening.
Thank you. Lisa?
Good afternoon, everyone. My name is Lisa White. I work for Boston Public Health Commission Healthy Baby, Healthy Child program. I'm one of the PHAs, or what you call community health worker. And I heard a lot was being said in reference to pay for the PHNs in the program. However, we as the advocates are the foot soldiers of the program. We are home visitors who go into the homes of any of the clients that need our services, and we provide them with information, referrals, and resources that are needed to keep their lives going. I feel it's very important that we speak about this just because we are just as important as everybody else in the program. We're still waiting on our increase in pay as well, so we're hoping that that comes through very soon. We thank Dr. O for trying to work with us and getting things done. Thank you, sir, as well, our lawyer here. And we want to make sure that the city understands that we are the foot soldiers. We see the clients, we act with them, we believe in them, we get them what they need, so we also need you to support us through this whole job thing, and we really need pay to reflect what we're doing, and we're hoping that that can come through very soon. Thank you.
Thank you. Now we're just waiting for virtual testimony, and at this time, I just want to acknowledge that we've been joined by Councilor Santana. Whitney, the floor is yours.
Can you hear me?
Yes.
Okay. Good afternoon. My name is Whitney Golden, and I'm a social worker at a local community health center located in Boston. I'm here providing testimony today in full support of fully funding the pilot for the community-based mental health crisis response. I was one of the 14 community members that worked alongside the City School and Boston Liberation Health to design the community-led mental health response. Because being that I'm a BIPOC resident of Boston and a social worker, the idea of something like this being offered in the city really rang true to me. This kind of response has some key components that I believe will contribute to those in need, along with their families and friends feeling better supported in their search for support. One of those components are no police involvement. Speaking from personal experience, I've worked with young people and families that hesitate and sometimes avoid altogether seeking support for themselves or a loved one due to police involvement. I have firsthand knowledge that people have felt unheard, have bad past experiences of feeling unsafe and victimized at a vulnerable time in their life. I had a family I worked closely with show me a video where the mother was seen yelling at police that her child needed mental health assistance, and you can hear the fear in her voice as she tried to ensure his safety and well-being as the police interacted with him. And at one point, interacted with him. I bring this example up because that should not be the case for any human being experiencing a mental health crisis or having to bear witness to one. I also say it because I want to distinguish intention from impact. In this example, I am unequivocally attesting to the negative impact that this encounter had on the very person the police were called to help. Whereas the impact of programs like the one we propose today have been restorative on different levels and have had a hand at helping such individuals get what they need so that they themselves can start working toward making themselves whole. In addition to no police involvement, another component that I think enhances this mental health crisis response is that this plan seeks to hire BIPOC people with lived experience, and community members. The importance of these components are to ensure that the people serving the community come from that community and have a comfortability and connection. In my expertise, this is important in a therapeutic encounter because it allows for a potentially in-depth, unique, and safe space for seeking assistance. Again, I implore you to fully fund this mental health crisis response. Thank you.
Thank you. Want to thank everyone who came to testify publicly. Thank you for your time and thank you for your advocacy. Now we'll turn back to our council colleagues for a second round of questions, starting with Councilor Flynn. The floor is yours.
Thank you, Mr. Chair. Again, thank you to Dr. Ojikutu and to Tim Harrington and the public health team that is here, but also that is doing exceptional work across the city in all of our neighborhoods. I highlighted some of the issues I focused on in the first session, and just want to go over some of the other issues that I didn't highlight, but I'd like to cover as well. Dr. Ojikutu, can you tell me about gun violence as a public health initiative, and why is it critical that public health plays such a critical role in gun violence prevention, in gun violence education?
Thank you, Councillor Flynn. So many of the root causes of gun violence are public health oriented. So it's really critical that we be involved to address those sometimes very complicated underlying drivers of what we see, particularly in our urban centers around the U.S. I think before, in the earlier few hours ago, I was asked about sort of the root causes of violence in our communities. And I think that one of the issues that I mentioned is, of critical, many of the issues, but one of the issues in particular was of critical importance in regards to public health. And this is really about building community resilience, building community strength, building community advocacy, and ensuring that community members feel as though they have economic mobility, that they have strength, that they're being respected, that there are programs, strategies, interventions available to them, and really feel like they're a part of it. They're not disenfranchised, they're not marginalized. I think that we know from studies that when you have community strength, when you have social capital within communities, when there is that sense of resilience and community empowerment, there is less of what we would see as sort of the predictors of violence. So that's a big piece, and that's a lot of what we do at the Public Health Commission. Other drivers, as we've mentioned before, if you think about some of the issues related to substance use disorder, and we think about, gang violence, and we think about many of those issues that I know you're very much so involved in, we do focus on that, particularly in terms of not just intervention, but prevention, and making sure that people, have other alternatives, that they have the supports, the social supports available. If that does become a concern or an issue within our Recovery Services Bureau and within our CAF Bureau, so within the Child, Adolescent, Family Health Bureau. I think it's complicated, but certainly a lot of what's happening in terms of community violence is rooted in the sort of strategies and frameworks that we use in public health, and that's why we are critical to the process. But I would also say that we're doing this in partnership with public safety. So this isn't just something that is a public health issue. It's certainly something that we have to do hand in hand. And I think we have a really good partnership with BPD and public safety currently within this administration, and that's been extremely helpful.
Thank you, Doctor. I know we talked about this prior to the start of the meeting, but I do want to ask it publicly. The SHOPS team, needle pickup, critical public service that your team provides to all neighborhoods across the city. Tell us the status of the program, exactly what are they doing? What are residents, when they see these needles on the street, what is the response residents should take? In contacting city officials, I do want to give an opportunity for you to highlight this program because they do play a critical role, but also to educate the public about the SHOPS team.
So we have a very active mobile SHARPS team. They are critical to the work that is happening across the city. Certainly, we don't want there to be needles or other works that are disposed of inappropriately around the city. That's a public health concern that we definitely want to continue to fund and support. We do have this mobile SHARPS team. These are outreach folks who respond to 311 complaints about needles that are seen or other paraphernalia that are seen throughout the city. They work every day, not just picking up SHARPS, but also doing other really critical work that I think is of importance. I would say that not only do they respond to 311 calls, but they work proactively. So we go to the parks, we go to areas where we know people are congregating and using, people living with substance use disorder, and we make sure that those areas are clear. I think that that's important. but it's not everything, obviously, that we need to do. I mean, people still see, disposed paraphernalia around our city, and that is a problem. So we have to begin to think about how we're managing substance use disorder and people who are, actively using in a way such that that is less of a concern. And I know we've had ongoing discussions about how we manage it, but certainly it's an important service that we have to continue to fund. We also have the CSRP, the Community Syringe Redemption Program, where people who are living with substance use disorder bring in used needles and they get a small token. So it's sort of a workforce development type activity. In that process, they are also supposed to be engaged in services, developing relationships with that team, and hopefully learning more about harm reduction, naloxone, referred to services if they are interested in that. So we have a number of active programs that are ongoing and I think are really important.
Thank you, Doctor. Well, I only have 20 seconds left. I'm not going to ask a question, but maybe after the hearing's over, if someone from your staff can get back to me and let me know about some of the outreach on illegal gambling, but the education aspect of it and educating our immigrant neighbors about the dangers of, obviously, of gambling, the impact it has, but also how are we reaching residents that might not speak English. But we can talk after the hearing, or if someone from your staff could get back to me. Thank you, Doctor.
Thank you.
Thank you. Councilor Braden, the floor is yours.
Thank you. Thank you, Mr. Chair, and thank you. I think this is a question more about capital. I'm very focused on capital this budget cycle, but in BPHC has 11 capital projects, 9 are managed by public facilities. And what is the Commission's involvement in public facilities department and the City of Boston's Office of Budget Management to just move the thing project? Just because you get some money appropriated doesn't mean the project moves along in a timely way. I'd love to understand just your relationship with that process.
Yeah, so we meet with OBM and the public facilities team sort of multiple times during the year to go through all of those projects. We actually meet with them 3 different times during the year: the fall, in December when we're going over our, the next budget plan, and then we meet with them again at the RF2 stage in the spring. And so we go through all of these projects. We continue to sort of advocate for some of them. There's been some that have been on the list for a few years. We understand they've got projects across the city for all agencies. But they've been picking up the BPHC projects fairly timely over the last couple of years. That one that I mentioned in my slides, the HVAC system for 201 River Street, which is the transitions building in Mattapan, that one's been kind of hanging out there a little while, but that one has been approved. That's an important project for that particular building. They've had some issues out there. That's one of our core residential buildings that we have here at the Commission. So we do meet with them regularly to just continue to advocate and to continue to push those projects forward.
That's good. I know some of them get stalled and we can't all get everything. Also on the financial side, your external funds, you have 66,460,000. How much of that is actually federal grants? I looked through, there's a long list of grants that you get, so.
I don't want to guess, Councillor. A good majority of it is, it includes a lot of the opera funds that's sort of winding down over the next couple of years, but I can give you a better breakdown of that. Yeah.
And I'm just wondering, just in terms of your process, like the federal grant requirements are different because they have this sort of uniform guidance requirement. Is that a burdensome process, or is it fairly manageable?
I think the answer from our grants team would probably say yes, but we do have a robust finance team and a grants office that handles all of that for us. And then we do have an outside auditor, Clifton Larson, that comes in and provides an internal audit for us, but then handles all of those audits that are required by the federal government for that.
Very good. And then on the tech and data side, I see you've got 21 full-time equivalents this cycle. I'm just wondering about your interaction and working relationship of BPHCs with Do It. Like, you know, how do you have a relationship with Do It to support your activities? Like, one thing now with the planning department coming into the city, I'm very excited that, you know, have data collection and reporting and research and analytics and policy and GIS and then just good demographics. Do you share licenses with Do It, or do they? What's their support with them?
So there's good connectivity between us and Do It. Our chief information officer meets with their leadership on a regular basis. We talk to them as we think about some of the dashboards, you know, that we've implemented, which I think have been really important, you know, as we think about like pathogens and respiratory viruses and so on and so forth, as well as other aspects. We are separate in a number of ways, and I think that those are ongoing discussions about how to best interconnect. Mm-hmm. So that we are more easily able to talk.
Interface with each other, yeah.
So those are some ongoing discussions.
Very good. And then back to our conversation, we had some of your public health nurses here. I'm concerned that they're working in similar workplaces as school nurses, and this pay differential. Do we have any sense of what it would cost to compensate the public health nurses commensurate with what BPS nurses get?
That is a good question, and we will take that back and come up with a number for you. Mm-hmm.
How am I doing for time? I've got 2 minutes left. Wow. Let's see. I really appreciate the whole attention to gun violence, and I remember when I came here first, my first job was at Boston University Hospital, and one of my first training was somebody from public health coming in to talk to us about gun violence, and then, you know, everything shut down. We weren't even allowed to do research into the causes of gun violence. So I really appreciate your work in that space. It's critically important, and, you know, if we can reduce the toll of young lives lost, it would be really helpful. I'm scrambling to find I can always give up my time to somebody else, but I'm loath to do that. The noise ordinance, how many people do you have working, how many full-time equivalents have you working on that now? I know you get eight complaints a week, so is that like one person or?
Yeah, it's a small number. We'll get it back to you,
yeah.
The FTs.
Yeah, because living in an urban area, noise is a big challenge. Mm-hmm. Okay, thank you, Mr. Chair. I think that might be all my questions.
Thank you. Councilor Mejia, the floor is yours.
Thank you, Chair. And the next time I'll take Councilor Braden's time. I volunteered to take it.
59 seconds.
Yeah, I'll take every single minute that I have. I worked really hard to get in here. So I just want to thank the folks who have spoken. As you all may know, then Councilor Wu and Councilor Edwards and I worked on passing that ordinance, the alternative to 911. And so you have my deep commitment at making sure that through the budget process that we continue to ensure that we are fully funding the pilot. So I just want to go on the record and reaffirm my commitment to the work that we did in 2020 and 2021. And considering that it was Mayor Wu who worked alongside Senator now Edwards, I'm going to assume that there's going to be some energy to ensure that that vision continues to thrive here. So I just wanted to thank you all for your advocacy. And I also would love to just talk a little bit about the issue around health and the intersection of reparations I established the Reparations Task Force, and I want to thank Harvard School of, I don't know what it is, but some Harvard
School of Public Health, yeah.
They invited me. I don't know, because
Ethics
I don't
speak.
really like Harvard all that much, but they invited me to speak. And they already know that. But I don't know why they keep inviting me back, but I still come, right? But I was, and thank you, Tammy, you were a part of that. I was talking about the intersection of reparations and health, and I'm just curious from a public health lens, you know, what are some of the things that you can point to when we're thinking about reparations and the intersection of public health?
So I appreciate all the work that's been done in regards to reparations, so thank you for leading that charge. There has been a lot of work at a couple of institutions that has been very instrumental, I think, in putting the data out there. One way to look at the issue of reparations is this is really one of a series of bold actions that we need to address the wealth gap, and we know that wealth is really so deeply interconnected to health. If you think about individuals in this country who haven't had access to economic mobility, who therefore can't weather financial shocks, and they have nothing in the bank, you know, when something bad happens, and they have unsecured debt, and when they are faced with challenges, they just can't seem to get through that, and they may have good jobs, you know, I can think of, you know, friends of mine, you know what I mean? So, and yet at the same time, you don't have wealth. Therefore, you're not able to spend money on the kinds of health care and the kinds of health and wellness activities that you should have and that you should be able to afford. So it's a major problem in this country. We know that there's a huge wealth gap between black and brown individuals and white individuals, and it's something that we need to do something about. Reparations, that's one strategy. As you well know, there are other strategies that I think are really important, including ideas around baby bonds, including ideas around, you know, just cash transfer, you know, guaranteed basic income strategies, all of which I think we're all talking about across the administration, and it's something that I know that for us, as we look at the gap in life expectancy, the gap in infant mortality, the gap in premature mortality, all of that can be narrowed with better economic mobility. So.
Right. And then when I think about reparations, it's just not about economic mobility.
More than that.
I'm also thinking about, you know, the quality of life in terms of the living conditions, in terms of BHA housing. I'm thinking about the asthma rates. I'm thinking about, you know, infant mortality and black maternal health issues. I'm thinking about what it's like to go to a community health center oftentimes and not be seen or heard or affirmed, right? So those are all part of the reparations conversation, and I just want to thank and acknowledge that some folks are really looking at bringing that into the space. But I do have another question in regards to the nurses in particular. I asked the question not even knowing that we were going to have folks here talking about migrant and the uptick, but now that that has been brought here into the chamber, I'm curious in terms of just infrastructure, and cultural competency, right? And looking at so many of our healthcare needs for children in particular happen in our Boston public schools. That is the one place where kids are going to get their needs met. And I'm curious, as we are continuing to have these conversations, what are some of the things that you can point to that can help support your work?
So in regards to the diversity, the wonderful diversity that migrant populations, non-US born individuals bring to our city, I think you have to have a culturally diverse, linguistically diverse, you know, workforce. And I think we've made strides in that regard. We can provide you with specific data in terms of who we actually have hired at the Boston Public Health Commission, but I know for a fact that we have made efforts within our homeless shelter to bring in at least part-time support that is of Haitian background and speaks Haitian Creole and is able to communicate with the migrant population, and we will be looking at staffing as we move forward. I think in other areas, certainly particularly amongst our nursing staff. I would say that we have made an effort to be more diverse, and we've been acknowledged for that actually by other providers, because we're bringing a different sort of skill set to the table that other entities may not do. And so I think overall, though, we have tried in terms of recruitment and retention to be diverse in terms of who we are hiring and who are the sort of frontline workers who really represent the city at the Boston Public Health Commission.
So let's talk about the Alternative to 911 mental health pilot program, specifically around some of the, this call for fully funding it and supporting it. Can you talk to me about where that stands and what can we do on the council to help support that advocacy?
So currently, we have a pool of money. It's not the $2.6 million that's being called for. We have, I believe it's $1.5 million in total. And increasing that really is a discussion with the mayor's office, and this is a broader discussion than BPHC, as you well know. We're fully in support of the community-led design group and are looking forward to the RFI as well as RFP and the pilots going forward. And we sincerely appreciate the advocacy by the community, by the groups who are here, by folks who've been working on this now for multiple years. And so whatever you can do to support that, I think is very helpful, would be very helpful.
Okay, thank you. And I've reached my time.
Thank you. And just to clarify, we're at the RFI stage right now.
RFI, yes.
Which is
request for information.
right, which is fully funded on.
Yes.
Okay, and then will be the RFP and then the pilot program.
Exactly.
All right, Councilor Fitzgerald, the floor is yours.
Thank you. We talked about the low threshold sites, the $1 million needed as the ARPA funding starts winding down. Where, for what sites are those? Where are those located?
Okay, so we have 6 sites currently. We have 727 Mass Ave, which was the newly funded site that was stood up in November in light of the encampment. We have a Friends floor that's within 112 Southampton, so it's in our men's shelter. So it's one specific dormitory where there are beds for men who are living with substance use disorder. We have the Willows program, so that's number 3, Willows program that's in the Woods Mullen shelter, which is the women's floor, and that's not actually run by us, it's run by Victory Programs, just to be clear. The cottages still exist, so they will exist until the end of June, and they are run by the state, and they've contracted out their services to several providers. So Pine Street Shattuck also has a site for men that's located on the Shattuck campus. And then we have Envision Hotel, which is in JP. That is, unlike the other sites that I mentioned, except for the cottages, it's really, they're a more congregate type environment. This is really a hotel type shelter space. And I only mention that to say that the diversity of the type of sites that we have available is unique, and I think it's important because we have people, who are either in couples and won't leave the street without their partner, or they've been restricted from congregate sites and need to be somewhere else, or for various mental health trauma issues, they need to be somewhere else, and that has occurred for a variety of different reasons within congregate settings. So I think those are the 6 right now.
And so they'll all be with one closing down, but the cottages that would be over by the Shattuck. So with that, there'd be 1 in JP, the other 4 would be in the South End.
Exactly.
Correct. What is the capacity of the Woods Mullen shelter? I have not yet to visit it.
Okay.
Or
No. I would have to look it up.
No,
I don't want to tell you I don't want to tell you the wrong number.
Yeah.
The entire shelter? Oh, I think we had 143 on average in the entire shelter. I think I was looking at this data before, but I thought you meant the Willows program.
No, just in the shelter itself.
Okay.
And is that, so, but this 1 million for the low threshold site would only go to the Willows program, not the overall Woods Mullen?
Let me let Tim
Shelter.
talk more about the funding.
Yeah,
Tim?
I mean, I think the 1 million we're going to use it generally to continue to support the 3 sites that BPHC has been funding, which has been 727, the Willows, and the Friends floor, which is in the 112 Southampton. space.
We can talk about Envision. So Envision Shelter, the hotel space that I think you know, as I was describing, that is a space that we would like to maintain. The state will no longer be funding it as of the end of this year, this calendar year. We would like to step in and use some combination of our funding to keep that open, just because it helps us to move away from the south end and have some space somewhere else in the city. And it has been very successful in getting people off the street. A lot of those individuals have gone on to permanent supportive housing. And like I said, there are people who can't go into congregate shelter. So it's a very desirable place. And we are looking for support. We've met with the state about this multiple times, and we will continue to try to make sure that that stays open. And some of the funding that Tim's mentioned is related to that.
I appreciate that, especially with the concentration of shelters being in the south end, and looking to decentralize that, and always the hope, of course, decentralizing the services provided in the south end, as the overall attraction for what is, impacting my constituents in that area. So I appreciate that there are efforts to decentralize, and I hope that continues on not just the shelter side, but the other services as well, going forward. The Sharps versus the Community Syringe Redemption Program, what is the difference?
So the Sharps program is basically just going out, a team of folks go out with a picker, as the tool to pick up the needles, the Sharps that people have left after utilization.
Is that what I did when I went out with your team? Was I with the Sharps team then?
Yeah, I think you were with the Sharps team, yes.
Okay.
Well, you were with our outreach team. No, you weren't with Mobile Sharps. You were with our red shirts.
Yes.
That's what I think, okay. So I unfortunately wasn't able to join you that day, but you were with the red shirts, and they were going to meet people where they're at and talk to them about engaging them in services, provide harm reduction supplies, and potentially get them a place to stay.
And but we picked up needles.
And some of them pick up, yes, they carry their picker with them.
Yeah.
But we have a team of folks who also dedicate, that's what they do, right? And they do other things, but that is, they will go out to respond to 311 calls. And they will go out proactively to the parks. So it's something, because, we have such a challenge, most cities do, we do have lots of people who are engaged in that practice. The CSRP, that's a novel workforce program. By workforce, I mean that it engages people living with substance use disorder in the process of collecting used needles, whether they be their own or others that they see. They bring the used needles in, and they exchange them for a small token, money. And, they use it as they will. But the point is, one, to pick up the needles, but then the other piece is that they should be engaged in services in that interaction. They should actually be talking to somebody, and harm reduction supplies, naloxone, as well as questions about drug checking, for substances. That should occur in that process. So it's a strategy that's not just about picking up the supplies. It really is about being more holistic.
Gotcha. No, I get it. You draw them in, say, reward them, cleaning up, but also connect them to services as you make that connection with them.
Exactly.
Right.
Exactly.
Versus the Sharps team that just goes out and says, we're just picking up.
Right, and the Sharps team, those are people who are employed by us, right? So those are, right, so these are the people who are doing the CSRP, those are people living with substance use disorder who are unsheltered.
And is the CSRP money, the token that folks get for maybe returning their needles, that money is provided by who?
That's provided by the contractor, so it's provided by us.
Right,
So we pay.
but so is that ARPA money now?
That
or
is ARPA money, that is
currently?
ARPA money,
But
yes.
we'll be looking to, I know we just talked about in the last round, the decrease in that program.
Yes.
But we'll still be looking to fund that portion of it, even if it's decreased, we still have money.
Through opioid funding or some other source.
And they get, is it cash, or what do they?
They get a token. To be honest with you, it's not that they're handing them, I think it's $10 maximum per day that we're giving people.
Yeah.
And then they're getting that. They're part of sort of a program, and then they can utilize that. But
And they can spend it on what? I just want to make, are we giving them money that they can then use to buy more drugs? Is that if they're allowed to do what they want?
They can do what they want with it. They can actually do what they want with it.
Okay.
I think I understand your concerns here, and
Yeah,
this is
no, I'm
part
just-
of, well, but no, these are part of our concerns also, and we've been thinking it through and trying to figure out what makes most sense. The reality is that these are people who are living with addiction, you know, and that they are going to use anyway, and we're trying to mitigate risk, right? Not, you can't control every aspect of it. So try to engage them in some way, and then go from there and see if we're if we're actually improving things, which I don't know. I don't have an answer for you. Remember that's what I was talking about with evaluation. Councilor Fitzgerald, it's actually 147 beds. I think I said 143. I just want to correct that.
You're always right in the ballpark, though.
Well, but I like to be accurate. So.
I'm right there. I appreciate it. Thank you very much for your time. Thank you, Chair.
Thank you. Just a couple more questions, Dr. Ojikutu. We constantly hear from our young people on some of their struggles around mental health. Can you talk to me what Boston Public Health Commission is doing around our youth, and also how we're working with, whether it's BCYF, Boston Public Schools, to help them create policies to help be supportive of our young people? I know last week, the conversation around banning cell phones in schools, I'm not sure if that's something that, you guys would like to weigh in on, touching on, your thoughts on that policy, but also just how we're supporting our young people.
So, the Center for Behavioral Health and Wellness was established, in 2023. It was actually established in 2022, I believe, initially, to specifically address the issues that you're referring to really address mental health issues amongst youth. And we knew that there was a problem. I mean, everybody, I think, was very much so aware. During COVID, things were highlighted, but these issues, preceded COVID. We knew that there just wasn't a lot of behavioral health services. There's stigma in terms of accessing services. So then the question becomes, what can we as a public health department do about it? So I think one of the first task was to figure out, well, who are the partners and who are the people who we should be talking about this with, and certainly BPS has been a major partner in this effort. I think one of the aspects of this is, first of all, making sure that enough services are provided in schools. So clearly, that was a big piece of the $21 million from the ARPA fund. Well, some of it's from ARPA and some of it's from other sources. So providing enough mental health supports within schools, but also thinking about how to make our schools and our school districts really trauma-informed. And I think that's a key cultural shift, actually understanding how important trauma is in terms of, health outcomes for kids, in terms of educational outcomes, in terms of families. So it's not just about the child, it's about the caregivers, it's about the household, and making sure that all people, including the adults within the schools, actually have some understanding of how to manage behavioral and mental health issues beyond what they would get in their sort of normal sort of onboarding and, skill set that they develop working in the school system. So I think those are the key pieces that we're primarily focused in on. There are certainly other aspects that we're working on. If I just mention a few other things that are happening across the commission. So certainly we're working with early childhood mental health within the CAF Bureau. So thinking to ourselves, okay, where does it all begin in terms of mental health challenges? And DCF is a partner in that. And we work with them to identify very young children who may be at risk, whose parents, have challenges, may have their own struggles that we need to intervene on and provide case management, link them to mental health supports and care and treatment, which is incredibly important. Those are pieces that I think are ongoing, as well as involving parents in Healthy Baby, Healthy Child. Obviously, trying to get people linked to mental health supports as we do home visits. You heard from the nursing support and our community health workers, actually utilizing them in that way to make sure that everybody feels as though there's somebody to turn to. I think one other piece that I know you're very involved in is looking at the Community Healing Response Network. I think a big piece of that sometimes, it's not that it's overlooked, but it's it's important as you think about healing. It's not just about the outreach team that's out there doing the work. It also is about the connection with community health centers and behavioral health, mental health supports for those individuals who've been exposed to community violence. So a lot of the work that they do is provide referrals to family members and to community members who feel unsafe, who feel traumatized by whatever has happened in their community. So that's an important piece of the work. That's just a snapshot of some of what we do. I think, that gives you a sense, but certainly there are other aspects of the mental health supports that we offer.
And I love the health report that you guys do, that you guys also, decided to go in the community and give that report out. But when we identify, some of these disparities or issues within the community, whether it's like asthma, heart disease, or what we identified, are we identifying also the service providers and making like a map of like in those communities where community residents could go, and also making sure that we're, pushing for the investment in those neighborhoods to provide?
So I think that's the critical piece. I mean, you can't just create data and then disseminate data and then leave it at that. I mean, it really has to be, so what are we going to do about it from there? So I would say that in certain critical areas, we've taken steps to engage people and to, make sure that we're doing things differently to address the actual need. So one example is the colon cancer campaign that I mentioned during the presentation. Like, for example, we know that Black individuals have the highest mortality rate from colon cancer. So the question is screening not early enough? Is there some other underlying, maybe genetics, something else that's happening there? What is actually going on? Is there access, mistrust? What is it that's happening in our communities? So what we did was we then engaged key stakeholders, community members. We talked about the data. We thought about what it is that would be most important in terms of information dissemination. And it really was awareness in many ways. That people just, don't know and don't necessarily advocate for. There are fears around colonoscopy, and so, well, if there are fears around colonoscopy, maybe there are other strategies, which there are, that one could potentially use for screening. And getting that information out to people and making people aware that we have seen an increase in colon cancer, particularly amongst young people of color. So these are all things that people need to be aware of. So that's an example of how we could take the data. And the data that we produced, particularly around cancer, but across all of the Health of Boston reports, that tracks back to, in some cases, 2015. But these are persistent inequities, persistent disparities. So it's taken time, and I think over time we've sort of built if you will, a toolkit or things that we do and we will try to build on going forward to continue to address the challenges.
All right. And then my last question is, I'm a big advocate for a Bureau of Violence Intervention or Community Violence Bureau, seeing that, now we're having the domestic sexual violence inside of the violence department, and then also just community violence within itself is it's a big topic. So, what are your thoughts on, pulling that department out and making it its own bureau?
So, violence is a top priority for the Boston Public Health Commission, and certainly, I think, for the mayor, certainly an incredibly important challenge. And you've been very much so involved in the leadership team and having these discussions. The way that we're looking at this is there a better way to resource, to amplify, to highlight those needs? And yes, we believe that there are some strategies that we could utilize, and one of which that we have been discussing and has certainly been discussing with you, but certainly is discussing internally, is making the Division of Violence Prevention its own entity within the Boston Public Health Commission with a direct line of report to me, so that these issues can be repeatedly highlighted, though I repeatedly highlight them anyway, but you understand. So it does say something, I think, externally when people see that. These are ongoing discussions. And I think it's not a process that can happen quickly, and it's probably not a budget neutral process either. So we have to figure a lot of details out before we can make that change, if that happens.
And I just want to thank you for all your collaboration, your whole department. You guys have been, just great. I don't know if Councilor Mejia has more questions. You have more questions, Councilor Mejia? The floor is yours. The floor is yours.
Thank you. I'm good.
Yeah, and just looking forward to continue working with you and your department on all the issues here in the city of Boston.
No, I really appreciate that, Councilor Worrell, but I do want to thank all of the staff, every level of individuals at the Boston Public Health Commission. I really do think that they put forth a tireless effort, and they're probably the most dedicated individuals that I've really worked with in my career. So I just want to thank them for all that they have put forth and the effort they have extended to make Boston a healthier city.
Yeah, no, I agree. And I was going to start naming names, but I know I'll miss it.
That's why I don't do it.
Just thank you to the whole department. Thank you. And this hearing on dockets number 0670 through 0678 is adjourned.